Well, good morning, everyone. It's Pete here from the Paint Toolkit, and very good morning from a very sunny UK at the moment. As you know, we've had, well, like most people in Europe, we've had a lot of flooding and whatnot. A lot of places say that we're still above water, etc. Hey, listen, welcome to the very first European Supported Pain Self-Management Conference. And myself and Grania Daniels, I'll introduce in a minute. We thought about this a few months ago, I think, when we was having our little meetings over there in Suffolk, etc. And because up until now, we've only been doing these sort of conferences for worldwide, etc. But we was getting some comments from people saying that, yeah, but I love the conferences, but I don't want to. If you live in Europe or UK, you do want to get up at 2 o'clock in the morning to watch them, etc. So we thought, well, let's get our act together. So this is the second one myself and Grania have organised. We did one for people in Southern Hemisphere a couple of months ago, but hopefully this will be the first of many European ones, because self-management now is really taken off. I was at the, I think it's taken off. I was at the International Association for Study of Pain Congress in Amsterdam a couple of, sort of sitting here in August. And I was really taken aback by the amount of people that kept approaching me, wanting to know about supported self-management. How can they get involved in it, and so they can support their patients. And it's even being mentioned now with the World Health Organization, the European Pain Federation, and British School of, not British School of Motoring, that's the word for them years ago. British Pain Society, and so the International Association for Study of Pain. So this is to me, where with self-management, we're getting into these conferences coming in at the right time. So today, I want to introduce you first to Grania Daniels and Dave Oxley. They're supporting this conference today. So good morning to you, Grania.
Good morning, Pete. It's lovely to see everybody here this morning. And it's especially nice to, as you say, not be doing this at 2 o'clock in the morning or some other ridiculous time.
I know.
where I'm just trying to keep my eyes open. Very excited for our speakers this morning. Very grateful to them all for giving their time and expertise and lived experience to share with those people who have registered and who will be able to either watch live or listen back at any time that they like. This is something that we are both really passionate about. We've kind of really kicked off. We had our Southern Hemisphere one a few months ago, which was just really brilliant, and there'll be another worldwide one, I'm sure, coming your way soon.
February. Yeah, February next year. So, Grania, can you tell you'll be concentrating on something today? You're going to be concentrating the chat. You're going to explain to the.
I am, yeah. So it's people who are watching live and who are with us. Anybody who has any comments or questions they want for any of the presenters, please do just pop them in the chat function, and please also feel free to pop your name in there and say hello, say who you are and where you're from. That's always nice to get an idea of those people that are watching and listening live. And then at the end of each presenter session, I will go through and ask the questions, and if there's time and people then want to ask those questions live, we can see if we can sort that out. But depending on how many questions there are, I will go through them all, and we'll try and answer as many of them as possible. So yeah, just pop them in chat function during the speeches and during the talks.
Okay, thanks, Grania. And also we've got Dave Oxley. Good morning to you, Dave.
Good morning, all.
Good morning, Dave. Dave is behind the scenes guy. He's IT. Dave, I got to know Dave a few years ago. He started coming to our Pain Toolkit cafes, and he's like me as a pain self-manager, and he works with me on this, and also works with me on the Pain Toolkit Academy that we launched earlier this year for healthcare professionals. So, Dave, I know, do you want to say anything about what you're going to be doing this morning?
Yeah, so if anyone's got any tech issues, just message me privately. If you're not presenting or talking, then please stay on mute and turn your cameras off. Once we get the presentations underway, I'll be spotlighting all of the presenters so that they should appear on your screen, and then we'll play you around with that afterwards for the Q&A so that Grania and Pete can come back on screen. But yeah, if anyone's got any questions, ping me and I'll happily help you offline or online, whichever.
Okay, Dave, thanks very much. So for me, although we've organised this conference, myself, Grania and Dave, it's really your conference, because this is in true supported self-management terms, really, it's we just organise it. And the idea of the conference is to not only support people with long-term pain, etc., but it's also for healthcare professionals as well. And I noticed by the names on the screenshot I'm showing you at the moment, we've got three healthcare professionals who are going to be talking about supported self-management. And also we've got three self-managers like myself, Dave, and we've got Keith and who else we got here? I can't remember now. Oh, sorry, Ruth. It's getting old business, mate. I'm not a big fan of it, but anyway. So we like to. It's a balanced thing, in other words, because this is how pain or supported pain self-management works. It's about teamwork, but between the people living with persistent pain, but also the healthcare professionals who support them. So, and what we're doing as well by evening it up is actually role modelling to the big organisations, etc. That people with pain, self-managers, we need to be part of the conferences as well. I know Remco sort of demonstrates that, because I'm going to talk a bit more about Remco in a minute. But he invites me along to the conferences that he organises. So, but if we can get like the British Pain Society, the European Pain Federation, and the International Association of Study Pain, those big guys, okay, we need to. It'd be great if we was co-presenting with the healthcare professionals, because, hey, listen, they're telling me, not just me, well, the World Health Organization, IASP, they're now quoting 1 in 5 people around the world living with persistent pain. And I've been involved in this now for 30 odd years, and it's still, there still seems to be the same old problems like going on, through lack of communication, etc. I'm only going by the emails that I get, etc. So it's so important that we all work together. There's no one's got the answer, but we need to be more inclusive how we work together as a team. Anyway, so that's enough of me. So I'm going to stop sharing my slide. I'm going to hand over to Remco. Let me tell you a little bit about Remco. I met Remco a few years ago. A good friend of mine, Dennis Martin from Teesside University. He told me about this guy that runs this organisation in the Netherlands, VR for Health. And I've always been interested in technology to a certain degree, because to me it's how do we engage people, and I think like giving someone a leaflet, perhaps like the pain talk, etc., that's great, but the kids these days, they're using VR and other technologies to get their information, and I've been hooked on that ever since. And going to come away from that very first conference in Nijmegen at Remco, that inspired me to look at how can I get into VR. And I suppose I've put together like what I call a pound shop. It's like a discounted store. Perhaps you haven't got them there in the Netherlands, but like it's free to use platform, and so the VR I use. But Remco to me is my go-to guy if you want to know anything about technology, especially with virtual reality. Not just here in the UK, but to me, he operates in the whole of Europe. And I think we was having a chat yesterday. I think the next conference, hopefully you'll mention that later on, Remco, is going to be in Italy. So Remco, do you want to get your slides cracking? And is there anything I missed out, by the way?
No, you said it perfect. You said it all. Thank you so much.
Okay.
The gentle introduction. I'll try to share my screen for you guys. Here we go. Okay, good morning, everybody. As Pete introduced me, I'm an innovation manager in a hospital in the Netherlands. I'm fascinated about the chance technology gives us, digital technology gives us to help and support rehabilitation for people in pain, but also for people who face trajectories in regaining strength in rehab, in all kinds of rehab situations. So I'm very pleased and honored that you've asked me to talk a little bit about that in this conference. Again, if you have any questions, we have room for that later on. But I'll simply tell a little bit what I do, what I came across, what my thoughts are, and then hopefully we have a good conversation about that. Let's have a look to the next slide. This is a project we're doing. It's called Scale Up for Rehab, and scaling up, that's basically the name of the game right now, because there's a lot of digital technology out there and available, but it's all, let's say, a little bit hidden. It's all in little pilots. It's not big yet. So we thought we might as well develop a project, and I'll show you a video about this project later, where the aim is to truly scale up the technology that can be very useful and effective once we find the key to expand and broaden its use. Well, this is the place I work. It's called the St. Martin's Clinic. It's a specialized hospital focused on people with problems in posture and movement. So we're the largest center for orthopedics in the Netherlands, the largest center for rheumatology, also the largest center for spinal cord injury recovery. But we're a pretty small hospital. We have an annual turnover of about 180 million euros, which is small for a hospital, and also in the number of full-time equivalents in people, so about 1,300 people work there. But dedicated and a nice place to work because we're focused on these few things. Well, I started with virtual reality for pain back in December 2016. I came across a company in the US called Applied VR. And there you have the first pictures of what we did with it. It was basically a Samsung telephone with some with an app running on it in a plastic holder for a headset. Of course, the Americans charged me a whole lot of money for it, and we started working in the pain department with that app to see whether or not people were into that. But well, pretty soon people gave very positive results. So we expanded a little bit. A few years later, we went to the Oculus Go, and it's fascinating to see, whatever the age or whatever the treatment, people love to be in another world. And this is it's pretty easy to use. You just put on the headset, and if the nurse has helped you do the settings, then you quite easily can find your way through the several options and several programs you have, and it's relaxing, or it's a little bit engaging. And there were some games, there were some videos. There's a lot of things to be discovered and explored. So we thought, well, this is something which can be quite impactful. So and we also use virtual technology in our rehab center. This is a bigger machine where candidates walk, so to speak, in a 180-degree screen, and they have to do dual tasks. So let's have a look at the video. So for safety reasons, people are hooked up to the ceiling. we use markers on their feet to see exactly where they are. And this is a typical patient with a stroke patient. He has to learn how to walk again, and you see the dual belted treadmill, and he's walking. And here's his therapist following all along. But you see, we capture the movement. There's another child doing a kite game, so they have to walk and also play the game at the same time. And again, the therapist very close, and you see he's cheating a little bit because he's holding the handrail. All right. Okay. This is another project. It's called embodiment. What we can do, we can manipulate a little bit with virtual reality. And we, in this video, we shown it in 2 different colors. The candidate has to move her hand, and one of the colors is the real movement she's making, and the other color is the, let's say, exaggerated movement the candidate sees in virtual reality. So you can see in real life is the yellow hand, but what she actually did is the red hand, and she needs to move her hand and let's say move through the pain and let the penguins slide on their hand. And if she stretches far enough, then the penguin actually will make its move. And so this is called embodiment, because the candidate only sees the hand in VR and don't see exactly the move. And then you can manipulate the brain a little bit, and the therapist on the tablet can manipulate the settings in that perspective. So very nice thing to do, a kind of a the trick of the mind, but very helpful for the patients. And over time we can let's say put the settings like that in the end of the therapy, the real hand and the virtual hand are in exactly the same positions. This is another project we did. This is a candidate sitting on the back of a stingray. This trajectory is called Trunky Excel. And by regaining trunk stability, that's the basics for learning how to walk again. You see there are markers on the back of the candidate, and through motion capturing we can exactly see where she is. And again, the therapist can look at a tablet and see what she can make it, let's say, a little less easy or a little easier, all according to, let's say, the performance of the candidate. So in fact, you can say this is therapy that is tailor-made. And the nice thing about this one is that this project was, we started this project with the help of patients. We did a hackathon, so to say, and in the hackathon, the first ideas for this intervention came up, and it's now on the market. This is a project we saw in Australia. It's called Reality Health.
If this was a real fire,
and then again, this is a very good educational VR impact where you can where you get in a few steps easily explained what pain is, how that works, and how that functions.
You think your hands
And
know,
this is again a very powerful tool to explain how pain occurs and why it's important to understand, let's say, how pain is formed. And it has some very scary effects, like standing on top of a cliff, and other VR impactful things. And it helps people to understand what they're going through, and hopefully it helps them in their self-management.
You can work out the rule with these objects. It's not supposed to be easy.
you can now see
All right.
a
Well, this is a German VR concept. It's called Curio, and it's built for stroke patients. And again, what it does, it can personalize the treatment, and that is of course very important. It's not one size fits all. No, it's what you do with it and how it helps you in your exact trajectory. And it's fun to see. You see people smiling doing it, and again, the therapist can exactly see what's going on and can adjust in the panel how to help the patients as much as he can. And of course, it can be playful as well. Some gaming is there, and it's completely it has the complete MDR, the medical device regulatory acceptance. So it's been paid for, being paid for by healthcare insurers as well. Now we do it again. Well, this is a beautiful art kind of thing that helps people with regaining control by because this game is completely controlled by breathing. Candidates have a marker around their chest, and or they can use the pedals to in the same rhythm as their breath, as you can see here. And then as the better you let's say sync your breath or control your breath, the calmer you get, the more engaging is your adventure in the deep sea is going to be. So again, this is an award-winning prize concept, and the people who've made this have just released a new project called Soul Paint. If you ever have a chance to see that, that's an even better one. But unfortunately, I'm not allowed to show that yet because it's still in the race for prizes and so on and so forth. So with all that technology on the market, I thought, how can we help to scale up these technologies? And I was thinking about it. How can we truly scale up all this virtual reality technology? Well, not by trying to bring all these technologies one for one to the market. No, I have to find a distribution model in order to do that better. So while we're in Corona, I think a lot of us were using the Netflix as a way to relax and to enjoy ourselves. And the nice thing about Netflix is that it's available in practically every country. Content-wise, it may vary a little bit. For instance, Netflix Germany has probably more German movies, and Netflix in the Netherlands more Dutch movies, and Netflix in the UK maybe a little bit more UK movies. And there are also some big Hollywood movies that are available in Germany, the Netherlands, and the UK. Same goes with the fee for Netflix. It might be a little bit different in Germany than in the Netherlands, but the procedure or the technology is basically exactly the same. And once when a video is online in the UK, it can easily become online in the Netherlands as well, or as soon as we have, let's say, the translations ready. So I was thinking, could we build a Netflix for digital therapeutics? And with that idea, I went to the European Union with the Interreg subsidy program, and they approved it. So we're currently building, let's say, a Netflix for digital therapeutics, and there's a small video about that as well.
If we could enable people to do their rehabilitation exercises from their own home. We believe it would be a huge step towards high quality care, but affordable, accessible, and available for everyone. That is why we are building a virtual rehabilitation clinic, a clinic that enables blended care, easily accessible from your own home, and where your healthcare professional supports you in every step of your rehabilitation process. Blended care is the future of healthcare. Not only is the technology efficient, but also very effective. But it's not just us who are very excited about this new project. Also, patients, practitioners, and app developers are very enthusiastic about this.
The main challenge we are facing with patients undergoing rehabilitation.
Oh, we have a crash. Let's see if I can go back there.
I think just needs to hit the play button again on the left-hand side.
From home, or sometimes it's hard for them to visit the clinic, for example, when they are less mobile.
Yeah.
Because it doesn't always fit my schedule.
Sorry about this, Pete.
Don't worry.
Uh, I'll try it again.
And
Okay.
that sometimes they find it hard to do their exercises from home, or sometimes it's hard for them to visit the clinic, for example, when they are less mobile.
For me, the biggest challenge in my rehabilitation process is doing the exercise at home, and also having to travel to the clinic because it doesn't always fit my schedule, or I'm not always able to travel.
What would help me and my patients a lot is if we can use a blended care solution where I can start the treatment here in the clinic, follow them all the way into their home, and in the meantime, we can customize and adjust the interventions along the way.
My rehab process would be faster and more pleasant if the exercise I'm doing would be more fun to do.
My main motivation to develop these apps for people to use at home is to make healthcare more affordable and more accessible in the future. What I see as a unique advantage of digital rehabilitation is the fact that you can use virtual reality technology to make it more fun, more engaging to do your therapy. And in the end, that also speeds up the entire therapy process, which is a win-win for everyone. Digital innovation is not a game you can do alone. And that's why I invite all of you to join us in the Scale Up for Rehab project.
All right.
Is that the end there, Remco?
Well, that is the end. Well, I have 2 more slides.
Okay, yeah, go for it.
I'll again, let's have a look. All right. Well, what we did is since there's a lot to be learned to be learned in extended reality rehabilitation. That's why it's not only virtual reality but also augmented reality, because some treatments work better in an augmented setting. We formed an association or a collaboration and innovation network. That's what it's called. So we started this last year. We have now 42 members in 20 different countries in the world joining, and we organize conferences, as Pete mentioned. Next year is going to be the 5th conference we will be doing, and we will do this in conjunction with one of our Italian partners. So I can now announce that the next year's Exalt for Rehab conference will be in Lecco in Italy. That's pretty close to Milan. So if you want to learn more, then please join us in June, end of June, 26th, 27th of June in Lecco, and come talk to a lot of researchers and business people about this. The virtual clinic, as I just presented in the movie, is currently built, and let's say the minimal viable product will go live at the end of March, and by the time in June, let's say the clinic will be fully deployed. And we are currently talking to a lot of people who want their services on this platform. What it then does is that, like Netflix, it's available throughout the world. So that's nice. For the countries where we can make deals with healthcare insurers, it can be being paid for as well by your healthcare insurer. It can give direct feedback to your therapist. We can do professional reviews and studies we can show, so people can find their way, choose what they need, and go there. And then a small link to self-management. In the Netherlands, we have the ISA, that stands for let's say the integral healthcare pact, and that's basically our roadmap to the future. And in that roadmap, it's very funny. It starts with healthcare. You should do it yourself if you can, at home if you can, and digital if you can. So I think in the next coming years, in order to keep healthcare available and affordable, we all should focus on self-management, self-care, and if you need a little bit support, we call it blended care. But the delivery of the healthcare will be more and more digitized. It will be more and more in your own home, maybe with the support of some technology devices such as virtual reality headsets and what have you. But that's, let's say, one of the only chances we have to keep the healthcare system running. So with that, I would like to open and invite you all for questions, should you have any.
Well, thank you, Remco. As usual, puts a lot of wind in my sails, you know, when I hear, you know, about what you're explaining, what you're doing, etc. And I think what you're doing with the Netflix concept is all about building capacity, because, you know, sometimes with sometimes you know, what I find in healthcare is that it's very you know, very focused, sort of tunnel vision, as I call it. And you know, when I worked in the NHS on a program called the Expert Patients Program, it was all about building capacity. In other words, how do we get the word out there, not just to the usual people that sort of engage with healthcare, but those that don't, you know. So a lot of the work we did was outside of the usual parameters, like, you know, we went and spread the message in prisons and the travellers community and also the minority groups, etc. But to me, I love working with you, man, because it's so, I just think it's so innovative, you know, because, you know, a lot of this is it's a way of cutting costs down. I mean, for anybody on watching this, you know, I ain't got to tell you, if you're living with pain like it, it's a miserable existence. And it's what using technology is about, you know, learning some self-management skills enable us to move on. Hey, listen, I'm going on too much here, but has anybody got any questions for Remco? Have we got any questions in the chat, Grania?
There is a couple of questions. I was just asking Dave if he could let me start my video, but I can do it without the video, I guess. There was certainly lots of positive questions, lots of positive comments. This was really nice, Remco. There was a lot of feedback for the relaxation slides. People really liked those. That really sort of seemed to hit a note, the breathing ones. And particularly I find that because when I'm trying to do myself breathing exercises, I do often find that my head starts to get a bit busy, even though I'm trying to concentrate on my breathing. But having that visual thing to focus on, like the flowers opening on that journey you're going on, it was just almost instantly like something that you could get your breathing to work with. So it's such a fabulous way to see that. We had, I did ask a question about, I was really interested to know, you know, obviously in the UK, our healthcare model is publicly funded, so there isn't necessarily the same opportunities for individual trusts to purchase different sort of things. So I was curious how much, if you're aware of how much VR is being used in the UK, or whether you have any contacts with hospital trusts over here. One of the people who's on the course today, Leanne from Northern Ireland. She's saying that one of the Belfast trusts in Northern Ireland is using some VR technology. But I just wondered if you knew, if there is a lot of it going on in the UK.
Yes, the UK is a front runner, I would say, in a lot of VR technology. I recently saw a very clear study published by the NHS on the use of virtual reality in British healthcare. So I'll send the report to Pete, and then he can share, because it's all publicly out there. But still, a lot of hospitals don't know how to start, or don't know what to do, or don't know how to. So this is exactly the reason why we need to scale things up.
Yeah.
Because people who once see it or once do it, they immediately feel, hey, there's something out here. There's something. This is a new technology that could change the way how we have our interactions between patients and practitioners. What if we could give, let's say, the people this breathing exercise, as you just mentioned, in their own home, and wouldn't that be nice and engaging to find it out yourself and actually experience that that it helps you on the spot. And so yes, we also work a lot with Professor Dennis Martin in the Teesside University. He's one of our people there. We have Joseph McVeigh. He's in Ireland in the University of Cork. We have Brona Fullen in the University of Dublin. So we have, let's say, in what we call the coastal islands, Ireland, United Kingdom. There's a lot of things going on over there, and a lot of good companies are there as well. But but worldwide there's a huge vibe. There are a lot of companies in the Netherlands, a lot of companies in the Nordics. Finland is very good, and of course the USA. So if you and once you're into this technology, it's you basically meet it everywhere. Everybody's looking, is experimenting how it's working. So it's a very exciting time for let's say for virtual reality interventions.
Yeah, it is indeed. I've had a question again from Leanne, wanting to know, as a physiotherapist, how can she get involved in using VR outside of working in the NHS in the UK? How does she make contact with people to sort of start getting involved in using VR?
Yeah, well, if you have any specific questions on specific technologies, please send me an email.
Yeah.
I think my contact details. So I'm more than happy to help find your way there. There are a lot of let's say companies offering a lot of things, but again, you have to look at the rules. Is it truly a medical device, or is it something else?
Yeah.
Because there's also the principle of first do no harm also applies. So you have to be sure that if people have a brain injury, let's say a very engaging flashing game could lead to stress or other problems. So please beware. But I'm more than happy to help you, to introduce you to let's say serious and interesting companies who are working and developing and studying in this field.
Yeah, cool. And then sort of she says thank you. The last note on there, it's not so much a question, but sort of a musing from Lizzie about thinking how this technology could really help people who are on inpatient wards for considerable lengths and periods of time, away from nature and in an environment which is often quite threatening in many ways. There's lots of noise, there's lots of beeps and medical things going on. So kind of that would sort of obviously make them feel quite anxious and threatened quite a lot of the time. So it's just a sort of thing to say, maybe there's also potential to use this in an inpatient environment. Is that something that's done in the Netherlands?
Yeah, that's done. We do it in our own hospital just because of this. We see in our rehab center a lot of people with spinal cord injuries, they let's say after a skiing incident or after a motorcycle accident, they come to us to recover and regain, let's say, sort of control about their own on their own body, although this body has changed. For instance, people can never walk again, or and have to then cope with a body that is different than before. And as you can imagine, these people are often anxious and in pain and in distress and so on and so forth. And then if they then would have a device in their beds to get away or escape a little bit from it all, that's very helpful. So let's say our nursing staff is then able to, let's say, bring a headset and help people on their way and find their let's say as kind of a relaxation. We also have these things in our pain treatment facilities as well. We did a project with partners in Belgium. They even had it in the special care or extra care units, the intensive care units.
Okay.
So even there, people could escape or do their first mini trainings in the intensive care as well. So
Well,
yeah,
thank
you
you,
see it
Remco.
also at dentists, or you see it at all in our wound facility room. People who have wounds that need special needs. That's a lot of times painful and not a pretty sight to look at. And they then can put a headset on and escape a little bit from that all in this virtual world. They don't feel the pain or the as much as well. So this is how our brain works. If the visual input is stronger than the actual pain input, then people don't feel the pain anymore. Isn't that beautiful?
It certainly is an amazing reminder that that there are so many different systems in our body that can input information into the brain that can have an influence, a quite dramatic influence in what we're feeling and what we're seeing, and we don't, or up to this point, I guess I think in many ways we've not made enough utilization of those things. So this is a real leap forward. That's been really super interesting. Thank you.
Okay.
So Remco, thanks very much for your presentation today, and I'll just shout out to if I mean, this is fantastic work, and to me is a big part of the future in healthcare. So the best thing to do really is come to Lecco next year in near Milano, and come and attend the conference, the 2-day conference. I think it's the 26th, 27th of June. I think you said,
yeah.
26th, 27th. Come along there. I highly recommend it. So write a letter to Father Christmas. So, dear Father Christmas, please provide me with some funds so I can have a trip out to Lecco.
All right.
Remco, thanks very much again. I'll let you get on and enjoy your weekend. And so thanks very much for today.
Well, thank you very much for having me. And now I have
An
to
honor.
do honeydews, as always on the Saturdays. So,
Okay, yeah, go for it.
good luck, everybody.
Take care,
Bye-bye.
man. Have a good day.
Thank you.
Thanks
Bye-bye.
very much.
Right.
So, we'll have a little couple of minutes stretch before we go on to our next speaker, which is Nathan Hutton. So if you want to get up and move around, you can do. I'm going to have a little stretch for a couple of minutes, and I'll see you again in 120 seconds.
Hey, Nathan.
Hi.
Excellent. You're there. Good.
It's a good start, huh?
Yeah, they all get to go off for a break. I get to sit here and do all of the setup for the next one. I think it's slightly unfair.
It's an important role, though, huh?
Indeed, yes. I like to think so, but that might just be delusions of grandeur. So you should be able to share your screen with no issues whatsoever. It should all come up. There we go. Perfect. You've done this before.
Yes, it's not the first time.
So when we start when just after Pete does the introduction for you, I'll put the spotlight on you and I'll turn everyone else's camera off, and mute everyone else, so you shouldn't get any background feedback or anything like that. And Gronya will be collating the questions through the chat, and then when your 20-minute presentation's finished, she'll then ask you the questions, just so that you know how it's going to go.
Yeah, sounds good.
Okay, well, I'm back. I enjoy my stretch break.
Yeah.
Hey, Nathan, good morning to you. I was going to give you a bit of an introduction before I let you crack on. Just want to say thanks very much for giving your time up today to take part in this conference. Hopefully the first of many pain self-management conferences. But so how do I know Nathan? Well, I've got to know Nathan like most things these days by social media, and I was following him, I don't know, it must be a year or two, something. It feels like a longer actually than that, mate, if I'm wrong. But anyway, and to me, Nathan has been like a bit of an ambassador for pain self-management. And it seems like every time I go onto social media, he's off somewhere, and he's always talking about pain self-management. And to me, you're probably the best ambassador that I've come across in recent years to get the message out there. And I was lucky enough to actually meet Nathan in August at the European Pain Congress, and we had time to do an interview as well. But anyway, I'm hand over to you, Nathan. To me, you got a fantastic message to give others there, not only just to healthcare professionals, but people living with pain and self-managers alike. So I'll hand over to you now. Okay.
Yes, good morning, everyone. Thank you, Pete, for those kind words, and thank you also for inviting me today to give a presentation. So first, I'm very sorry that I can't attend the whole conference today, because I just came back recently from a conference in Bali, Indonesia. So I haven't seen my family for more than a week, so I need to spend Saturday with them, of course. But apologies for that, of course. So I'm a physiotherapist from background, and I also work clinically one day a week, still in practice. My presentation today is more or less focused on self-management support provided by healthcare professionals. But I was also trained as a self-management master trainer in the US. So I know how it is to provide a self-management program for people living with pain. So I was trained to train trainers for those self-management programs in the US. So let's get started. So I focus in this presentation on musculoskeletal pain conditions. And of course, these conditions, they will cause pain and reduce function. They often have a multifactorial origin. So there are more contributors to the condition. They occur in all ages, younger ages, older ages, but especially people with working age are affected. And these complaints are also often work-related. And we also see an increasing prevalence. More and more people have to deal with these musculoskeletal pain conditions. And we also see high costs for society, for example, caused by healthcare expenditures, but also if people cannot go to work, that is also costs a lot of money. So this is an important problem. So if you have a healthcare problem, a pain condition, what could it then mean to you? So it could mean that you need to deal with pain and disability. You cannot participate in all the activities you like. You have to deal with frustrations and emotions. You have to deal with misunderstanding. You need to accept your complaints. You have to use medication often, and you need to adjust your lifestyle. You need to make decisions. You have to work together on your work, but also with healthcare professionals. So basically, you have to find a way to deal with your condition. So dealing with persistent pain is a real challenge. And in scientific literature, there are some recommendations how care should look like for people with musculoskeletal pain conditions. And this is a kind of overview, a summary that I made. So pain management should be patient-centered. It should include a biopsychosocial perspective. We'll talk about that later. It should include shared decision-making, education, self-management, and exercise. And I will talk about the items in red today in this short presentation. So first, have a look at person-centered care. That means that the patient is regarded as a person. It's not only a patient with a condition, it's also a person, just like you and me. And it also includes a biopsychosocial perspective, and I'll give some examples later. It is about sharing power and responsibility between the healthcare practitioner and the person, the patient. It's about really building a therapeutic alliance between those two people, the healthcare professional and the patient. And it's also about individualized treatment. So treatment should really be individualized. And it's also about patient-defined goals. It's not the healthcare practitioner who decides about the goals. It's the patient with support of the healthcare practitioner who decides about their own goals. And that includes, of course, a shared decision-making process. And here are some examples what patients with low back pain said in an article. Take care and listen to our worries, concerns, and fears. Provide examples and resources. Reassure us and build our confidence. Be empathetic and supportive. Understand our goals and life circumstances. And put us in charge with you, the healthcare practitioner, working as a coach. So this is all very important, and it also highlights the importance of the biopsychosocial model in which we focus on the biological aspects, the psychological aspects, and the social aspects of living with a persistent pain condition. So the biopsychosocial model is very important. However, we also know from research that people living with pain often predominantly consider their condition to persist or recur of biomechanical or structural reasons. So they compare their body with a machine that can be broken and that needs fixing. And that is not really a biopsychosocial perspective. This is more the biomechanical perspective. And strikingly, we know that about 90% of these people said that these beliefs came from the healthcare practitioners. So healthcare providers can play a very important role in changing the beliefs about these musculoskeletal pain conditions. So I'm a physiotherapist, and this was found in research about the ability of physiotherapists to identify psychosocial factors in patients with musculoskeletal pain. And just to conclude, you can read it here, the available research suggests that physiotherapists lack confidence and ability in identifying these psychosocial factors. So we do need to do a better job. And this was only about identifying these factors. It was not only about addressing these factors, which is also very important after you have identified those psychosocial factors. So we know that there are some barriers for integrating a real biopsychosocial approach. So these include knowledge, skills, and attitudes of the providers. The environment and the context and resources are an important barrier. Role clarity is not my job, for example, it's the psychologist's job. Confidence, I'm not trained in this, so I don't feel confident in doing so. And patient expectations, because often patients, as we saw before, do not really anticipate or expect a biopsychosocial approach. So we are in a kind of vicious cycle because patients have these requests and expectations, and these are often based on past experience and common beliefs in society. And often, you saw that on one of the previous slides, these beliefs come from healthcare providers. And still, many clinicians continue to offer a biomedical focused approach. And then patients also have biomedically focused expectations. And these are also very important barriers, as was said by healthcare providers. And that barrier might prevent physiotherapists or other healthcare providers from changing their practice. And that lack of change could then, again, reinforce inaccurate patient beliefs and expectations. So we're in this vicious cycle. And I think together we should break this cycle. But I think it is a very important role for us as healthcare providers to break this existing cycle. So here you see some examples from the biopsychosocial model, the biological aspects, the psychological aspects, social aspects, and also some extensions that were made here in this study. So it's really about the bio. It's also very important to address those psychological factors like attitudes, beliefs, mental health, mood, the social factors, work, family, relationships, and you also see some extensions, including patient-centered care, stigma, discrimination, culture, religion, etc. So these are very, very important aspects. And in my opinion, self-management can be used as a practical approach to delivering person-centered care that incorporates a biopsychosocial perspective. So self-management, the biopsychosocial approach, and person-centered care are really related, strongly related to each other. So we wrote some articles and did some, in the past, some presentations about person-centered care for musculoskeletal pain. And this was an article that we wrote about putting principles into practice. And in this article, we include a framework for person-centered care. And this framework has 3 overarching themes. And this framework can really be used by healthcare providers to incorporate, to use person-centered care and a self-management approach. So these 3 overarching themes are a biopsychosocial understanding of the person's experience, person-focused communication, and supported self-management. And in this framework, we also have 3 phases. So the identification and goal setting phase, about identification, shared decision making, and goal setting. A coaching phase, which is focused on general self-management skills, but also focused on specific knowledge, skills, and tools, and an evaluation phase. And then we also have the therapeutic relationship and building the therapeutic relationship, which is very important, and that waves through all the main themes and all the phases of the framework. So building the therapeutic relationship is very important. And this is a definition of a therapeutic relationship in the physiotherapy context. So it's about a safe space and effective bond between the patient and the practitioner, both developed professionally and personally, when establishing connections and engaging in the collaborative work of physiotherapy. And it has shown that building a good therapeutic relationship gives improved clinical outcomes, higher satisfaction with services, and better adherence to treatment plans. So establishing these meaningful connections is very important. That means that healthcare providers should consciously be present, be receptive, committed, and genuine. And these meaningful connections are those in which patients feel they have been seen, heard, and appreciated. So that's very important. And we should, as healthcare providers, intentionally develop these meaningful connections. They don't exist immediately. We need to build these connections with our patients. And that can often be also a challenge. So Maxi Miciak from Canada made a nice framework for establishing these meaningful connections. And I will go over this very, very shortly. So the framework has 3 components. So the first one is acknowledge the individual. So you meet the individual as an equal. You validate their experiences and individualize the treatment approach. So some examples are just sitting at the patient's level, not too high. Affirm expressions of emotion or personal disclosures, and also adapting home programs by considering the patient's unique circumstances. The second part is give of self, and that can be done inside the interaction or outside the interaction. So you can share a part of your life or experience as appropriate. So you don't share your personal experience with every patient, but sometimes it can be appropriate to share your experience. For example, if you also have persistent pain, you can share that if you anticipate that this can help this specific patient. And the second example is speak with the patient's other care providers. So the last part of the framework is use the body as a pivot point. So clarify physical problems and solutions, facilitate the patient's connection to their body, and use touch as a physiotherapist to bridge a gap. So provide those clear explanation of assessment findings, cue patients to their bodies to develop the awareness, and also carefully handle the patient's affected body region. So one of the components of the framework that we made is person-focused communication. So it's important to recognize the context of the patient's entire life. It's a person with a life, with a family, those kind of things. And it also requires us as healthcare providers to communicate with patients in a validating, considerate, and non-judgmental manner. Of course, we have our judgments, but we don't share these. It's not about judgments, making judgments. So as healthcare providers, we then pay attention on what we communicate, but as important is also how we deliver our message, how we communicate using verbal, but also non-verbal language. And that therapeutic relationship then is a paramount to establishing a meaningful and trustworthy dialogue that facilitates disclosure and reflection. And that then promotes collaborative goal setting and decision making, which I showed you is very important. And that's the reason that also shared decision making is a very important component. And you can see here some shared decision making steps that healthcare providers can use. There are different models to share decision making, and this is one model. And also you can also, if you are a patient living with pain, you can also expect these kind of steps with your healthcare provider. So it's about outlining that there are a number of choices. As healthcare professional, we invite the patient to partner with us. We explain why we do this, but people might not be used to such an approach. We describe the nature of the problem. We elicit the patient expectations. We explain various options. We talk about benefits and harms. And then the patient also is involved in weighing up these benefits and harms. And then we explore if the patient is ready to make a decision and agree on the course of action and implement the chosen treatment, arrange a follow-up, and then evaluate outcomes and assess also next steps. So this is very briefly a short overview of a shared decision-making process. And that brings us to self-management. And of course, the whole day is about self-management. This is one of the definitions of self-management. Interventions that aim to equip patients with skills that allow them to actively participate in and take responsibility for managing their consistent conditions so they can function optimally. So it's really about equipping patients so that they have the skills, so that they can participate, but also they can take responsibility for their own health and for managing their condition. But we also know that self-management can be challenging and people will experience barriers. So I believe that support is required. So this is one definition of self-management support: a person-centered, collaborative approach used by healthcare providers to support people with health conditions to acquire the necessary knowledge, skills, support, and confidence to take an active and leading role in managing their condition in the context of their daily life. Again, it's collaborative between the healthcare provider and the patient. It's about support. It's about knowledge, skills, support, and confidence, very important, to take that active and leading role. So this is important, that we support people in their self-management. And I believe that self-management should be part of routine healthcare. So a few years ago, it was focused on physiotherapists. I wrote that physical therapists should use a self-management approach to individualize treatment for patients with persistent musculoskeletal conditions whenever possible. And now, a few years later, I believe that not only physiotherapists should do so, everyone in healthcare should do so. Also, I believe this is always possible. I think we should always use a self-management approach in our treatment, in our management. And then I think we should not only use this in persistent conditions, but also in acute and subacute conditions. This is a very valuable approach in all conditions. So when we look at physiotherapists, my own profession, they often understand the importance of self-management. However, we found in research that they have insufficient knowledge about the self-management core principles, do not sufficiently address self-management skills, focus primarily on education and exercise and on the biomechanical factors, and also found it difficult to integrate self-management support into their management, and also experience barriers, for example, patient expectations, and also had needs for knowledge, skills, and tools. So the identification and goal setting phase is very important to start with. So you identify the person's experiences, ideas, and beliefs. And then you evaluate the person's attitude, their self-efficacy, social influence, and knowledge and skills. So what is the baseline? Then address important self-management skills. So which skills do these people already possess? And which skills should you work on? And then you evaluate the expectations and openness to a self-management approach. People should be ready for a self-management approach and should also be ready to change, because self-management is about behavior change. So in that article that we wrote, we also include the self-management identification tool. And this tool can be used for all the phases of the framework. So it starts with, in green, some problem-solving skills. These are very important skills for patients with pain. So it's about obtaining support, working together, goal setting, action planning, monitoring changes, self-tailoring, managing decisions, and reusing resources. So we should support people with pain to obtaining these important skills. And we can also provide support with regard to more specific topics, which you can see right here on the screen. A broad variety of very important topics. So we can provide self-management support. We can change the behavior, attitude, self-efficacy, social influence. People want to change, they make a plan, and then they will show their behavior. But they will experience barriers, and we can provide support to overcome these barriers. And people need knowledge and skills, and we can provide these knowledge and skills in our self-management support. So just at the end of this presentation, some differences between patient education and self-management. Because often healthcare practitioners provide patient education and not really self-management support. And you can see here, self-management focus on skills, how to act on problems. The problems are identified by the patient. It really is focusing on these problem-solving skills that you saw on the previous slides. It's based on the theory that greater patient confidence in their capacity is very important, and then that produces better clinical outcomes. And the goal is increase self-efficacy and improve clinical outcomes, and not compliance as it is in patient education. So, also some other authors worked on this topic, of course, and I want to just focus on the delivery phase here from Alice Kongstedt to help patients to make sense of their symptoms. Again, teach these problem-solving skills, and then set patients up for successful experiences. Those successful experiences are very, very important. We need positive experiences. So don't make too high goals. People should be able to achieve their goals. And then provide tools to manage also pain and emotion. And it's not only about the patient, it's also about the social environment. So it's also about involving family, informal caregivers, partners, peers, and friends. Because it's not only self-management, it is together management. So I'm now talking for 20 minutes. So let's conclude this part of the presentation by, I think a person-centered approach is very important. And also involving that, having that biopsychosocial understanding of the patient and the patient's problem. Then use shared decision-making approach, and then coach to self-management. And I think that is for us as healthcare professionals, we need to learn this and we need to do a better job. And we see improvements nowadays, and that's very, very, very good to see. And I hope that I can also, as Pete also said, inspire other healthcare professionals to also incorporate this approach in their management of people with musculoskeletal pain conditions. So that was my presentation. So I open the floor to you, Pete, and for questions.
Nathan, that was fantastic. And I don't know what, you've just answered a question for me, actually, because I've always said to myself, what does this guy know so much about self-management? And then you, at the beginning, I'm taking it that you attended the Stanford course.
Yes. So that was a 1-week course indeed that I took there. So I learned a lot there, also the practical aspect, but because I did a PhD in self-management, but then I was only the researcher on that project. And then afterwards, I went to that course in Stanford to become a master trainer. And then I really learned how to engage with patients and to really practically provide self-management support.
Right. Grania, have we got any questions for
Yeah,
Nathan?
there's a couple on there. I think that's, thank you so much for that, Nathan. It's really nice to listen to, and I know quite a lot of them, but it's nice to have another physiotherapist who's really on board with the same message. And the common factor is we're dressed in blue, which is weird. Maybe all physiotherapists who wear this color of blue are into self-management. I think one thing you said there was really interesting, and you said it just there at the end, before I go to a couple of questions. And there's a real difference between us learning about how to do self-management with people and kind of the theory behind it all, and we learn how to listen and we learn how to talk. But it's then when you go and you do the active course yourself and you do the training to do it practically, that's when you realize, okay, this is a whole, doing this skill is a whole different thing than sort of theoretically learning about it. And you had that when you went and did that training course. I had it many years ago when I went and did a course on learning communication skills and counselling as part of my work. And I went in there, as often physios and other clinicians go in, sort of, I listen to people, I'm a really good listener, my communication skills are really brilliant, I think I'm really good at this. And then I actually did the course and had to do the active listening and the working with people, and you think, wow, this is actually a lot more in-depth and a lot harder than I thought. And I came out of that with a much greater appreciation. but found often when I was going back to do work with other clinicians that they had that same mindset that I had, that you kind of, I know this, I'm good at this, I have these skills. And it's quite a challenge, isn't it, sometimes to help clinicians make that shift between, as you say, we're very good at doing a lot of education of people, of kind of giving them information and doing that, but shifting that mindset to it being a much more collaborative process.
I think that is one of the main challenges, of course, because as a healthcare professional, we would like to help people and we would like to give them everything what they want. But we should change that because we need support them to obtain the skills that they need, and not only give them what we think is good for them and do some treatments, some passive treatments, or just give them prescribing some exercises. And that's a whole different approach for many healthcare professionals who were trained in the past, of course. And we also need to get rid of some things, delete some things, if we would like to provide contemporary care, I guess. But I fully agree with you. So yeah.
Yeah. I mean, and sort of Pete had one question in there, which we ask on a regular basis, Pete, don't we? Yeah. We ask this question almost on a weekly basis. Why do we think that it's still not routinely being taught in healthcare professional courses as an equal thing to a lot of other things that they learn, like anatomy and everything else? Why is empowering people and communicating with them and helping to support self-management not a proper module on a healthcare professional courses? Any answers to that?
No, I don't have that answer. I think it is improving, but it is mainly improving, I think, in physiotherapy education programs. But it should be, every healthcare professional should know about this and should also provide self-management support, because when people hear different opinions, different voices, that makes it even more difficult. So every healthcare professional should be trained in this to some extent. And then, of course, some professionals who are more involved in the management, like physiotherapists, they should, of course, need to have additional skills to really support this. And I think we are improving a little bit, but still, it is a big issue, especially also because if you include this in a program right now, then the next graduates will have those skills in 3 or 4 years after they graduated. But all the other healthcare professionals who graduated before don't possess these skills. So upgrading skills is also very, very important. But I agree. This is also a major barrier, because when it's not addressed in the educational programs, then it's very difficult.
Yeah, I did put a link in the conversation for anyone that's interested on a study that I came across the other week on Twitter, or X as it's called, which was a subjective, qualitative study done on physiotherapists implementing self-management techniques and the struggle that they had. And what was interesting is this was just interviewing the physiotherapists about how they felt about implementing this, because I think understanding, a lot of people will say they want to do self-management, they understand the need for supported self-management and why it's got to be done, but it is that challenge of when you get in a room one-to-one with somebody that you want to work with, you've got those challenges of your expectations, their expectations, that power imbalance you talked about, limited time appointments, all sorts of things. And it was quite interesting what the results came out of this was, and one of them was a theme of a challenge to the professional identity, of moving away from, kind of, I am a healthcare giver, I am a helper, I am someone who fixes things or makes things better, to I am just working alongside you and you have the agency, so and a feeling that they were underskilled in psychological and communication skills, which I think is something that I do think has been, and this is only my experience, I see in the shortening of courses that are going on at university, and in a lot of it being taken more online as well, in terms of seminars and learning online. A lot of that psychological and communication skills and those interaction skills, if people don't inherently have them, aren't maybe going to get as well developed as they might do in a course where they're working a lot longer. So it's an interesting read for anybody that wants to read that.
Yeah, so one thing to add to that, because I think that's very important. I also saw that study, and it really also emphasized what I just explained, that it's difficult to move from that healthcare reflex that we have. We want to help people. So this study was from the UK, and we also did some studies in the Netherlands, and there were also studies conducted in New Zealand. So this is a global problem, global issue.
Yeah. Absolutely. And I think it's a global issue as well in terms of, well, I don't know if it is a global issue. Certainly in the UK, we're seeing a shift towards shorter appointment times and fewer appointments. And again, more of those appointments being online or over telephone, which again, when we've established quite clearly there from what you're saying and what we know is that building of a relationship with somebody, that creating that communication with them and creating that therapeutic alliance, that power sharing executive, so to speak, is hard to do the shorter a time you've got with somebody. The temptation to jump in and show your expertise, make them believe in you, and it can really twist up that balance. Lizzie sort of said there that she wishes she could help everyone see that building a connection with someone is in itself a therapeutic skill. There's often and I know that Lizzie found this herself as a psychologist, there was often this thing that psychologists and that kind of skill of communicating and building an alliance was seen as a soft skill. It wasn't seen as a kind of a key skill. It was seen as a bit fluffy and a bit soft. But actually, if you can't build a connection with somebody, you're not going to be able to convince them to self-manage, are you?
Yeah, and I think one of the challenges is, as you also said, for example, in the UK, we have less and less time to spend with our patients. So it's even more impossible to build that connection. You cannot build a connection in 3 10-minute appointments, for example. So we need the time with our patients to build that connection and to provide self-management support, because we cannot do this in 10 minutes. This will cost time, of course. And that's also the system, the environment that is really not facilitating us to use a self-management approach.
Yeah. It's almost like we need a shift in, it's quite a big shift actually, back to if you have longer appointments, it's that saving money in the short term to save money in the long term. You know, if you can make a connection with people and really help people find their way early doors by spending some time with them, you're not going to have all of these interactions later on. I don't know what you think about that, Pete.
I'll tell you what I think. We need to move on. Because I'm very conscious of the time, and I don't want to break into Nathan's weekend any more than we have actually. So Nathan, thanks very, very much for giving your time to be part of this first conference, hopefully the first of many, and enjoy your weekend. I think going by watching people in the chat and etc. I think your presentation is been really useful for not only healthcare professionals but for people living with pain and self-managers. Okay, so thanks very much again.
Thank you, Pete. Have a lovely weekend all.
Take care. Have a good weekend, man. Take care. Bye-bye. So we're gonna be moving on to our next speaker. I'm just conscious of the time, and now we're sort of eating into Ruth's section a little bit here. Ruth, are you ready to present, or here we go?
I'm ready to go if you want me to go. Yeah.
I was going to say, if anybody wants to get up and move around, they can do, as I will be in a minute. Listen, and the other thing I need to remind myself, and I've been putting in the chat, the chat feature, the closed caption feature is on. So if you're watching this, you may have a hearing problem, or you just like reading the words that people are saying. And don't forget to turn on your chat feature as well. So Ron, I'm going to hand over to you to introduce Ruth.
Yes, so we're very excited. This is the first now of our lived experience experts that we've got with us today. And I'm really excited because I've not actually, we've not connected for a while, myself and Ruth, but we do have I'm just going to have to mention it, we do have a very weird little connection that we found out by accident, in that my niece and nephew attended the same primary school as Ruth's children in a little tiny village in Scotland called Hoogendijk. And it just is an amazing little connection. But aside from that, Ruth is someone who lives with chronic pain and lives well with chronic pain and uses many strategies and self-management techniques to do that, including yoga, and provides teaching for yoga, I think, on a regular basis. Is that right? So you're going to give us a talk today on how you have done your journey with self-management and supporting yourself, and where that's brought you now. Is that right?
That's right, yes. So, hi, as you heard, my name is Ruth Barber, and yes, I am coming from Scotland. I don't know if it was on purpose that Pete mentioned the closed captions before I speak. Is it a Scottish accent requirement?
No, it wasn't at all. It was it's my forgetting that people, you may have someone with a hearing impairment that may be watching. Okay, I'll let you crack on.
Thanks, Pete. So I haven't prepared a PowerPoint presentation. I'm afraid you're going to be looking at my face, but I do have some photographs which I hope I can share with you over the computer here. So I hope that works when I come to do that. So as I said, my name is Ruth Barber. I'm here, yes, in a little village called Hoogendijk near Glasgow. And I feel quite a big responsibility being asked by Pete and Gráinne to kind of share, I suppose, my life, which I can't do in 20 minutes, but I'm going to try. And that's my life living alongside chronic pain. So I don't work in a pain-related field, although I have volunteered for the charity Pain Concern. I've worked on their helpline, so have worked with people in pain through that. And I'm not an expert really in pain. I know that that's kind of the title that we're often given when people in pain talk about pain. I don't see myself as any kind of expert. But I'm going to share what I would consider a fairly unremarkable story, in the hope that that will kind of show how I've lived my life over the last 20 years. And I'm having a wee wobble there because I think it doesn't matter how much you talk about your own pain, it is always quite upsetting. I might have a wee tear because it is something that has affected my life hugely. So I'm a mum. My daughter is 10. She's out right now cycling. I said to my husband, please don't come back right at 11 o'clock. And of course, they came back right at 11 o'clock. So if there's a bit of disturbance, that's why. I teach yoga. I'm a yoga teacher, but previous to that, I worked in the NHS in health promotion. I was a physical activity specialist, both in psychiatric care and in the community. But I now simply work as a yoga teacher and looking after my daughter, which is definitely a full-time job. So I was wondering how best to describe my pain to you. I don't really want to highlight my pain necessarily. I want to talk about how I manage it. But I have recently been involved in 3 very quite unique research projects, and these are all very artistic, very creative. The first is called The Language of Pain. It's all about using art-based methods, I suppose, to express pain. The other is called Remote Touch, and it's about audio recordings. I'm at the moment working on recording an audio that will help to tackle social isolation for people like myself in chronic pain. And then another project that's about acceptance and accepting life in pain. So I'm telling you this as a lead-in, I suppose, to why I'll be a little bit, maybe I'll try to be creative in how I express my story to you. So I wanted to start actually with a bit of a kind of maybe flippant poem. I'm going to see if I can share, hopefully, a little picture here. This is what I would call maybe a broken chap that's sitting in the gardens of Dumfries House, a beautiful gardening place. I think he's lost his leg there. Is it the right leg? I don't know, my pain's on the right side, so I thought maybe that represented me. The hair definitely is me and that little person. So I want to share this poem that I wrote quite a long time about pain. So me, I have pain on this side of my body. It can't be helped by a pill or a hot toddy. If you're not in Scotland, a hot toddy is like whiskey and lemon to, you know, help like a sore throat. It is here, hot and burning inside of my leg, like someone piercing me with a hot, hot peg. And I find if I breathe, really breathe and be still, I can almost be me, not some person who is ill. The thing that is inside of me, it never ever does shut off. It's not like a cold or a bruise or a cough. And I still get all of those, don't you know? And they floor me just so. Because pain is consuming, it's screaming aloud, and it's with me and it's in me. And I suppose I have vowed to dance with this pain and to create a waltz and to embrace me for me in spite of some faults. I'm having a wee wobbly moment as I share that with you, but I'll just share a couple of drawings that I have done of my pain so that you can see the actual pain. I know if I was listening, I'd be thinking, what is that person's pain? So sharing it this way might be a bit easier. That's me, apparently. I have it's neuropathic pain around my hip thigh. Interestingly enough, I interpret that picture as being kind of very sharp and spiky. My daughter looks at that and she sees a dandelion, which is kind of showing all its kind of fluffy bits. So that's the pain that I have in my thigh. That's as a result of a kind of very minor injury that I had dancing. I also have facial pain. Apologies, this drawing is quite horrific. I should maybe have shared that beforehand, so do look away if that's a wee bit upsetting. So following a virus, I ended up with facial pain, and that is what it feels like to me, a kind of chewing on electrical wire, really quite awful type pain. So you might see that I don't speak particularly well because of that on that side of my body. So sharing that so you know my kind of history. So I've been self-managing my pain for just under 20 years, since I was 29, so approaching 49 right now. And at that time, in my 20s, before I had any kind of support around self-management, I would have said that I coped with my pain, but I wasn't managing it, and I'll explain the difference in a minute about that. I think, as I showed the pictures, my pain is a nerve pain. It's very a kind of jagged, spiky, barbed wire is what I often use to describe it. So at the time when it first occurred, I was coping. So I was coping on the outside, everything looked fine. I was engaging in life, apparently. I seemed fine. I seemed to be looking like I was living. I was, obviously, but you know, on the inside, everything was crumbling and disappearing. It was an act. It was a lie. I was putting on like an appearance, but then I was very fortunate to attend, funnily enough, the same programme that Pete attended, which is Input. It's the pain management programme at St Thomas's Hospital in London, where I was living at the time. And I was thinking about, you know, Input, and for some reason the character of Buzz Lightyear came into my head. I don't know why, comparing myself to Buzz Lightyear. He says, is it to infinity and beyond? So I think of Input as to input and beyond. So Input, the pain management programme, was very much a kind of catalyst for me in change. And I know Pete himself has talked about how it's kind of been his change factor as well. So I went to, it was a 4-week residential programme, and I know that I was extremely lucky to be able to, you know, attend that programme and to be able to step out of my life and kind of just be able to concentrate on managing my pain for those 4 weeks. Now, if I had to do that now, I wouldn't be able to do that because I have family commitments. So, you know, that was something that at the time in my life, I know I was very, very fortunate to be able to do that. So what was it? It was a programme that had a full team of staff. So Nathan was talking about collaboration. It was very much collaboration, and this was 20 years ago. So it's quite hard to hear kind of the other presentations and talking about things still needing to promote self-management. You know, I really feel that it should be there already now, because on that programme there was a team of psychologists, occupational therapists, physiotherapists, nurses, doctors, consultants. I'm probably forgetting something. There were kind of graduates of the programme that would come back and talk, and the emphasis was on relaxation, you know, doing this everyday movement, kind of stripping everything away from your life and starting again. So I was a fitness instructor. I find it really difficult to kind of have to start from scratch again with just moving, stretching, challenging like feelings, thoughts, behaviours that I had around pain and around kind of maybe my own views, culture around, you know, how I should be living. Pacing, of course, pacing, which is, you know, the absolute key to self-management. Assertiveness skills, I don't hear it sort of mentioned often, but for me, learning to be assertive in communicating about my pain, communicating the things that I need, that was really key for me. And things like, at the time, I got support on getting reasonable adjustments at work under, I think it was the Disability Act at that time. So a whole kind of range of support. And this then, when I left the programme, it didn't kind of stop. I then sought out psychological support. I very much needed that side of things to help kind of low mood and, you know, a lot of sadness, grief. So I then had quite a lot of psychological support in one-to-one after that programme. And it was kind of like a handheld process of then eventually then I was on my own, you know, managing, but it wasn't a here you are and off you go on your own. It was a gradual process. And I really want to emphasise that self-management is a long process. It's not, you know, trying something one day and hoping for the best and then, you know, thinking that it's failed. It really is a kind of commitment. And for me, this will make me a wee bit upset, I think, to say this. I don't think I had any choice. Excuse me, sorry. So I just had to kind of go for it, and it was an opportunity. You'd think after all this time I could talk about it, but it is grief and it is hard to deal with. So self-managing involves a lot of commitment, and when you're feeling really vulnerable, as you can see here, that kind of commitment is really hard. It's really hard to, you know, realise that you've got to manage and that there's skills to learn. It's very hard to do that. And I think Gronje and Nathan both mentioned there about the idea of kind of seeing something in theory and then being able to put it into practice. And I think I've always thought of self-management skills as being you know, very, very straightforward, very common sense. Can't read my notes now with my tears. And it is very straightforward. It is common sense if you're not in pain. And that vulnerability of being in pain makes it very hard. You know, things that look very common sense on paper are very difficult when you are in pain. I'm just going to breathe now so I can get through the rest. So I saw actually a newspaper article talking about, I think it was a book that had recently come out. Pete might know this more than I think it was something on Twitter. Something about, the headline was like, you can still feel joy even when you're in pain, which is absolutely true. But I felt it was very flippant, very I'm going to say too joyful, and I don't want to say that, but it just didn't get across the idea that managing your pain really is, you know, effort and work. It really does take time to do that. And I felt, you know, this kind of, sometimes these kind of headlines take away from how hard work it is to do that. But I think self-managing pain is like saying, okay, maybe the things that I've done in the past or the support that I've had in the past isn't working, and I need to scrap all that, or maybe you need to take some of that and put it alongside self-managing and I need to start living my life again. And I'm going to share the story of when that happened for me. I was at the pain management programme Input, and I remember this very clearly. I was coming up Westminster tube station. I think it's got quite a long escalator, so it's a very kind of like vision of coming out of this tube station. And for the first time in 2 years, I'd had my pain for 2 years before I attended the programme. I actually walked at what the Input staff would call a good quality walk. So I actually walked. I wasn't dragging. I'd got into this habit of kind of dragging my leg, limping, and I'd actually walked, you know, a real proper walk. And I thought to myself, I'm not going to go back to that kind of dragging of the leg. And I think it was quite symbolic. You know, I wasn't just dragging the pain, I was kind of dragging all the grief, all the sadness. And I nearly kind of strutted out. I don't think I was quite at a strutting point yet. Hopefully I'm a strutter now. You know, and I walked out and I was like, this is my opportunity. I am not going back to that person that, you know, was coping and not managing. So it was quite a kind of big moment for me in that. And I'm not saying everyone would have that moment, but for me it was. And it was a slow process after that, definitely. And it took a lot of patience to do that. I'm very aware of time. Pete, can I keep just going? I don't want to go over and run into.
No, you ain't got to go anywhere.
Okay,
mate.
okay. So when I left Input, I decided to try yoga. I live near Hounslow Sports Centre. I went along to their kind of community yoga class. And for me, yes, Pete, Big Ben did keep me awake. It was awful. And I thought, see, I'd never really kind of stretched or been that kind of person. So to me, I thought yoga is stretching. Yoga is definitely not stretching. So I went to this yoga class and I quickly realised that I was learning breathing, relaxation. These things will now be sounding familiar. Movement, stretching. I was learning to become aware of my own kind of ingrained history, my own ingrained culture that was preventing me from moving forward. In yoga, that's called samskaras. I hope I'm pronouncing that correctly. It's kind of maybe things that you're holding on to, values. So for me, that was kind of etiquette. I couldn't sit down, so I felt like I was rude everywhere because I had to stand up all the time. When did it really matter if that's what I needed to do for my pain? But I think I saw yoga as a quick win, actually. I saw that it was ticking a lot of boxes. I had this huge list of things that I was going to do so that I could manage my pain. You know, it was huge, and I'm going to get through all these things, and I'm going to do all this stuff. How am I going to do it? I can't fit all this in. And I thought, actually, yoga ticks all these boxes. It's got breathing, it's got movement, it's got, you know, a bit of thinking, self-awareness. And so at first, I did very much see it as, this is a quick win for me. I can tick off the boxes, but not for very long. I then did realise that yoga for me was going to be the thing that I needed in my life. I needed that kind of calmness, this sort of settling. And there's excellent research on yoga in terms of health conditions or chronic pain. I'm not going to talk about that or share that. I am quite a science and facty person, but you can look that up. The Minded Institute is a great place for kind of research on yoga with chronic pain. But I just want to share a very sort of small kind of extract, I suppose, of something that I wrote, an article on why yoga helps me. I named that article that yoga, I don't do yoga, that yoga happened to me, because I felt that in yoga I had found kind of a place where my life felt meaningful. I felt that my life it made sense. Yoga allowed me to kind of use postures and use breathing to enable me to quieten this sort of faulty alarm system that I had. My body was kind of alight all the time. I think I've got another wee picture that I can share with you just to kind of have this. It's of the nerves that are I can't remember the name of the guy now, my brain's not working, the kind of bodyworks thing, so this is our nervous system obviously. Mine feels like it's on fire all the time. I'm highly sensitive, you know, seem very prone to kind of being, you know, very alert for whatever reason that might be, probably some sort of kind of trauma type stuff in childhood, trauma with a small t, I would imagine. And I felt that yoga could really give me some sort of dampening down. It allowed me to feel, you know, feel calm, to feel that I could actually breathe and I could be. So I am a yoga teacher. I'm just going to very briefly show you me at work. There I am, teaching my amazing class in Hoogendijk. Here we are. And I think yoga for me allowed me to kind of feel that I could get through life without constantly thinking about the pain. So the VR presentation was really interesting for me. I don't know anything about VR, but it's kind of the same principle for me in yoga. It's something that allows me to distract from the pain. It allows me to do things without focusing, you know, all my brain and my leg and my face all the time. It allows me to kind of be free from it. So I wanted to give a couple of examples just of kind of how I put self-management into daily life. I've got loads of these. I suppose the vital skills for me are planning, you know, preparation, using, as I said, assertive communication. So before I'm doing anything or going anywhere, I'm always telling people, you know, remember, I've got chronic pain and I need to do this, this and this in order to participate that, you know, and that's always fine. A good example, I think, for me, which is a kind of just a very simple thing. My daughter has maybe a lot of events or, you know, things at school or gymnastics displays. And so I'm just always planning and preparing, you know, where I'll sit so that I can get up and move around. I might have to contact, you know, the people to say, you know, is it okay if I'm here so that I can move in order to, you know, manage my pain. And I'm not moving because necessarily I'm in pain. I'm moving as a preventative measure to stop kind of getting flare-ups, which I still get, absolutely. So I mentioned about sitting. When I first started the pain management program, I could only sit kind of well, I suppose. So this is maybe sitting well for 42 seconds. You know, that's not a lot of time, and there's not much you can do in life that you can just sit for 42 seconds. And by the end of that 4-week program, I could then sit for, I think it was 10, maybe 15 minutes. That meant I could be part of life a little more. And I did walk around for years with a little timer, and I would time absolutely, you know, meticulously when I was sitting. I don't do that now. Sometimes I might have to go back and do that, but you know, that sounds really quite hard work, but for me, that is what I needed to do. This for me was what I needed to do. I'm not as rigid now at all. Life doesn't allow me to be as rigid, but I had to be rigid in the beginning. One other just very quick story. I love going to the theatre. So before I had sort of pain management skills, excuse me, I went to see Cabaret with a friend, and I sat in an aisle seat, and I said, you know, is there anywhere that I can stand if I need to stand? And they called an usher, I'm not sure what they're called anymore, in the, you know, in the theatre said to me, you know, there's nowhere you can stand, you can't stand. It was a very small theatre, and I was like, oh, this is going to be awful. You know, I was having an awful time sitting, watching, you know, Cabaret. I was desperate to see it. And then I got a tap on the shoulder, and she said to me, would you like to go and stand in the lighting box? You could stand in there. So I abandoned my friend. She then ended up sitting next to a complete stranger, and I think ended up going for a drink with them, but that's another story. And I was sitting in the lighting box then. I had a wee stool I could sit on. I could then stand up. It was fabulous that they had given me that kind of, you know, arrangement. So then I was able to watch. So I'm telling you that story because I think, you know, asking for help and asking, you know, is great. I then moved on from that. I was desperate to see Hamilton, and my daughter and I, my husband, we went down, got the train down to London. We watched that 3-hour show, which was utterly amazing. You know, I sat for the whole time. You know, that definitely gave me a massive flare up, but that was okay because it was something that I desperately wanted to do, and I knew what to do afterwards to then be able to manage that flare up. I'm kind of rambling a wee bit now. I'm going to finish very, just one tiny little bit to share with you. And it's about kind of not just realising that that it's not all kind of how can I put it? It's not just about the hard work. It's not just about, you know, putting in everything. It's about finding things that are important. It's about finding things that are relevant, meaningful, you know, things that can give you some joy. So I always say to my husband, look, I live in pain. That's miserable enough. I don't want any other misery. That sounds like he's the misery. I'm not meaning that. So I try and find really joyful things that will make me then, you know, feel good about myself. And for me, that's being outside. We're fortunate, we live in, you know, beautiful Scottish countryside here. I love being in water. So all of that is really important to find joyful things. I'm going to share one quotation to finish in a very tiny poem. So there's a member of my yoga class who's also in pain. Some of you might know him, Tim Atkinson. He's written about pain. He said I could share this with you today. He attended an online class that I do yesterday, and he said, Ruth, I feel so much better for it because I simply did something. And being just in that moment, just being there, maybe just for that 1 hour, I felt in control again. He was having kind of a bad time, and he said, just for that 1 hour, you know, I felt okay again, and that made me feel better. And he said I could share that with you today. So I gave you my sort of sob story poem at the beginning. This is my more maybe positive poem. This is how I kind of maybe view my pain now. And it is, look how I changed, look how changeable I am, look how the pain can change. My soft sound became a face that's full of joy, open laughter, full and joyful. I care for all and others. Look how I change, how I wish I could be that free. You can, because I am, you are, and this is you. I'll finish my ramblings now. Thank you so much. I had loads to say, but I'm really aware of time.
Thanks very much, Ruth. I think to end on that, change, it is about change. Self-management does change it. There's no doubt about it. You're living proof it does, and it changed me, etc. Like, you know, and I think it changed me better as a human being. I feel more back, as I call it, in the driving seat, etc. Just quickly, have we got any questions at all?
Not any specific questions, just lots of comments. I mean, I just can't thank you enough for sharing that. I think and this for me highlights just why this is so important and so powerful, and why voices, I so appreciate how challenging that was for you, and I'm so grateful for you even through that emotion and have been able to share. But it's so important for healthcare professionals to hear those stories, to hear the challenges, but also the positives that come out of it, and to hear the reality of living with pain for people, as opposed to just hearing about it as a sort of theoretical thing, and especially just the idea that it is something. It's a journey. It takes time. You know, we often say that, you know, nothing, that when we're teaching or talking about self-management people, it isn't rocket science. A lot of those strategies, they aren't rocket science, but it is stuff that has to be worked at. And I think you acknowledged it there, that actually when you're in pain and when you're really struggling, it can be really hard to have that motivation or that energy to start doing that work. And it is definitely something that can take some people quite a long time to get there. There often there was for people a sort of a bit of a light bulb moment that helps take them on, but it's a lifelong learning process. It's not something that you also do self-management and then that's it, your pain's in a little box in the corner and you don't have to think about it. It's a daily ongoing process. So
I think just sorry interrupting you, it's also just, and I know it sounds a sort of scary thing to say, but it is, and Pete's mentioned it well, it is changing your life. But actually the pain has already changed your life. So it's about saying, actually, because of the pain, I now interact with the world completely differently. The world will interact with me completely differently. So let's kind of, I don't want to use the word embrace, but kind of let's do embrace that, because it is about changing your life completely, and that is scary to hear, but it's for the better. I mean, I kind of didn't get it out there because I was getting a bit upset, but you know, there really was no other option for me. I felt that I can't keep going on, so I need to manage it. This is what I have to do. There's no other way forward. And I know, you know, I'm maybe more dramatic than others, but for me, that was definitely, there isn't any other choice. I'm doing this and I'm committing to it. But I'm very aware, and I'm sure people agree, like how lucky we were, even though Big Ben was chiming every hour. That
we are very.
I'm sure it still is a fantastic programme, and being able to kind of get out of your life and do that, it is incredibly lucky to do that. I couldn't do that now, so you know, that is incredibly lucky to have done that then.
People that go on pain management programs, which like winning the lottery.
Yeah.
Many people here in the UK, many people in Europe, in fact around the world, do not get the opportunity even to have a sniff at going on a pain management program.
No.
So
And just could I just mention here, Pete, that I had to fight to get on the programme.
Yeah,
I was
me too.
pushed down the kind of, you know, get a, I can't remember what it's called, something, a stimulator, you know, and put in me. I didn't want it. I didn't want, you know, injections. I didn't want all these things. I was like, enough's enough. I want to learn. Even if there is a cure, I want to learn now how to manage this. But it was a big fight, you know, to get onto the programme. And I really hope that it's not the case now, that it's more available, you know, with kind of the internet. It's
not available. It's not available. It's been taken out the NICE guidelines for some, but you know, some.
But at least there's, you know, like the work you're doing, Pete, and there's Pain Concern, there's other charities that people can then turn to. I really hope, you know, to get help. So.
Okay. Ruth, thanks very much for your time.
You're welcome. I'm also not staying. I was meant to be going to now find a husband who's running a 52 mile marathon, but he's not doing it now, so thank goodness.
Thanks very much for your time today, Ruth.
Thank you. Thanks for having me. Bye.
Thank you. See you now. Ciao. So, our next speaker is Dr. Lizzie. Here's Dr. Lizzie.
Shall I do a little brief intro? Yeah, I'm going to do a little brief intro. So we're now handing over to my very good friend and ex-colleague, Dr. Lizzie Doherr, who's a clinical psychologist with a long time. She looks very useful, but she's got a lot of experience working in neuro rehab, traumatic brain injuries. She worked in chronic pain for a long time and is now working supporting cancer patients in Lincolnshire. And she is a fabulous exponent and taught me a huge amount about the importance of compassion, and that's what she's going to be talking about today. So I'm going to hand over to Lizzie.
Thank you very much, Grania. I just want to say thanks to Grania and Pete for inviting me to talk today. I've really enjoyed putting this together. Let me just see if I can do this correctly. There we go. Okay. Hopefully you can see that. So yes, as Grania was saying, I've worked as a clinical psychologist for 24 years now. And the longer I've worked in this role, the more I've come to believe that self-compassion really is at the heart of our general well-being, to be honest, but particularly, I feel, to effective self-management. So that's what I'm going to hopefully share with you today. Let's see. Let me know if I convince you by the end of this talk that self-compassion should be at the heart of your self-management plan. So I guess what I've been thinking about is, without self-compassion, my argument is that your self-management plan is likely to be incomplete. And hearing about the value of the pain management programs, I co-facilitated a large number of pain management programs when I worked in the persistent pain service with Grania. And as those programs progressed, I would say this element became more and more important to focus on. So what is compassion? So essentially, when we're thinking about compassion in this way, we're thinking about an ability to notice and turn towards distress and the desire to do something about it. So that's how we're thinking about compassion in this talk. So why am I focusing on self-compassion? Well, when I was putting this talk together, it really struck me that actually, surely the most important relationship we have in our lives is the one we have with ourselves. You know, we're with ourselves all the time, but I wonder if it's often one of the most neglected relationships as well. So I'm going to invite you to just spend a moment thinking about what kind of relationship do we tend to have with ourselves. So if you're willing to, I'd invite you to think about a time when you felt distressed, not your biggest level of distress, but just maybe something that happened that was difficult, was upsetting. Maybe something, could be something at work where you felt perhaps you hadn't performed at your best, or maybe to do with a relationship with a friend or family member where something happened that was difficult and a bit upsetting. So if you can bring to mind a time when you felt a little bit distressed, I'm going to ask you to think about, what did you tend to say to yourself about yourself? So in that moment when you were feeling distressed, for whatever reason, what did you tend to say to yourself about yourself? And I guess I'm wondering, and I find this with a lot of the people that I work with across all of the areas that I've worked since qualifying, is that we can often tend to relate to ourselves a bit like a bully, if this makes sense. So we can tend to relate to ourselves, think about ourselves, often with quite a lot of criticism, with a fair amount of judgment. We can condemn ourselves, blame ourselves, compare ourselves. So this may have come up for you, it may not, but if we kind of listen to how we're relating to ourselves, I wonder if quite a lot of the time we're not really aware of it, but actually how we're relating to ourselves is actually quite judgmental. We can also relate to ourselves, however, with compassion. So we can think about something difficult that's happened, some difficult experience we've had, and we can actually relate to ourselves more with kind of understanding, with kindness, with some warmth, with courage, with forgiveness, and with wisdom. So there are different ways that we can relate to ourselves. Now I'm going to invite you to think of someone in your life who you truly care about, somebody who's important to you, friend, family member, partner. Now imagine that they're talking to you about something that's distressed them, some difficulty they've had at work, some argument with somebody else. They tried to do something and it didn't work out. And I just invite you to think, how do you tend to respond to this person that you care about? Do you tend to kind of bully them, judge them, criticize them? Or would you tend to show compassion to them, to want to soothe them? And I'm kind of imagining that for many of us, when we think about how we tend to respond to other people in distress, we tend to bring in far more of this compassionate mind than the bully. So why does this matter? So I really feel that how we relate to ourselves when we are distressed truly matters a great deal for all of us, but maybe particularly when we're living with something like persistent pain. If we have this very judgmental, critical bully going on inside our minds, if that's the relationship we have with ourselves, firstly, that tends to build up tension for us. We tend to constrict. It tends to build up a sense of fear and threat, and it can increase our pain. In contrast, if we can develop this ability to show ourselves more compassion, to be compassionate to ourselves when we're distressed, then this can really increase our sense of feeling safe. So I'm going to invite you to kind of consider, what would it be like to meet our pain, our sadness, our anger, or our fear or anxiety with a sense of compassion rather than a sense of judgment? So I'm really asking if we can think about a way that we can hold our pain, and by here I mean our physical pain, our emotional pain, and all the distress that might come along with it. Can we hold all of that compassionately? So can we take the despair, sadness, anger, anxiety, whatever it is, can we hold all of that with a compassionate mind? One that's curious and patient, calm and friendly and warm. So really, can we hold our own distress and respond to it in a similar way to how we might respond to a loved one that we really cared about? Okay, so hopefully I've convinced you that that might be a good thing to do. So the next question is, well, how do we do this? So I invite you to hold in mind the idea that actually, can we have a choice in how we treat ourselves when we are experiencing distress? I would say yes, we can. And if we sort of narrow it down to the things that can be helpful, what to do when we are feeling some sort of distress. First thing, and I think Ruth demonstrated this brilliantly, you know, Ruth, when you were starting to feel understandably vulnerable, you connected with an emotion, you said, I'm going to take a breath. And that's just such an important first step. Can we actually, when we're feeling really distressed, just take a breath? There's a brilliant person that I came across when I worked in pain management called Vidyamala Birch, who is somebody who's lived with persistent pain for many, many years. And she does a lot of breath work to support people. And she has this brilliant saying, when in doubt, breathe out. So that's the first step when we're feeling distressed. Can we just take a breath, take a moment? And then can we become aware of how we tend to respond to ourselves when we're feeling distressed? How do we tend to talk to ourselves? Can we get curious about this? Can we start to notice it? And okay, we're not going to judge ourselves for judging ourselves, but we're just going to notice what we're doing. And then we're going to ask ourselves, am I being a kind friend to myself, or am I being a bit of a bully? So I really like this phrase, can we get curious? Can we become a kind of emotion scientist? Can we start asking ourselves, well, how am I feeling? What is this feeling that I'm having? What is this distress? Where do I feel it in my body? What does it feel like? And I actually turn towards it rather than trying to turn away or push it away. What am I feeling? What am I saying to myself? And then once we've turned towards whatever it is we're thinking or feeling, can we think about, well, which path do I want to take here? Do I want to keep heading down this red path? You know, this kind of critical, judging, blaming, shaming response to myself? Or can I actually deliberately notice and then shift into this green path, this kind of soothing, compassionate, kind friend? So at the point of noticing and taking a breath, noticing how we feel, we kind of have a choice about where we go next. there's a lot out there written about self-compassion, and it's an area which thankfully is being really researched and really brought into supporting people with living with a whole range of long-term conditions. But Kristen Neff is a big advocate of using self-compassion to help manage with, well, any condition, but actually with just being a human being, to be quite honest, with the distress and difficulties that just come along with living a human life. But she's developed this self-compassion break, which I'm a big fan of, and I do talk through with a lot of the people that I work with. And it's very simple, which is why I really like it. It has 3 steps. And it just literally talks about when you notice that you're feeling distressed, just turn towards it. Notice and name what you feel. Right now, I'm feeling anxious. Right now, I'm feeling sad. Right now, I'm feeling frustrated. Right now, I'm feeling really low. Whatever it is, just notice and name it. The second step she talks about is trying to remind ourselves of what she calls common humanity, which is literally to say, this is part of being a human being. We experience these difficult emotions. We know how common something like persistent pain is. A lot of people are living with this. But certainly things like feeling anxious, worrying that we've messed up, not feeling good about ourselves, or regretting something that we've done or said, that's just part of being human. There's a lovely phrase from a song from a while ago, which I love. REM did a song, Everybody Hurts. And that really helps me when I use this with myself. I remind myself, everybody hurts sometimes. So what do I need? That's step 3. What do I need in this moment to help engage this kind, caring, compassionate friend that I can be for myself? So there's a movement called hand to heart, which, if you can see me, but literally is just putting your hands over your heart, just taking a breath, just connecting to yourself. Maybe you need to ask for help. Maybe it's as simple as just saying to yourself, I'm here, I've got your back. What do I need? What do I need to do next? Maybe I need to take a break. So that's the self-compassion break. Do look it up. Kristen Neff has a lot of really, really useful information about using compassion to support us. So what happens to our pain self-management plans without self-compassion? So I would argue that you can have the best strategy advice in the world, but actually sometimes to implement these skills, which, as we were saying earlier, as Gráinne was saying, they're often quite straightforward, but to actually implement them requires, I would argue, a degree of self-compassion. So if we think about something like pacing, why don't people use pacing well? Because it's actually fairly straightforward to understand. So there may be some people who just don't know about it, and we can definitely support people to understand it, give them some knowledge. But I would argue that for many people, the reason they don't use pacing well is because actually they know that it could be helpful. But when they think about the need to pace themselves, they can either feel very angry about this. I don't want to be doing this. Why do I have to do this? Other people don't need to do this. This isn't fair. I don't want to be like this. I didn't used to be like this. Understandable kind of angry response to the need to pace. And sometimes people can just feel really, really low about it. They think, well, I'm not the person I was, and that's really, really hard. So they can start to feel really quite low. So actually, for many people, the reason they don't use something like pacing is because they understand it can be helpful. They have the knowledge. They might even know how to go about doing it. But all of this difficult stuff shows up that gets in the way. So how can compassion help here? Compassionate response to pacing might look something like this. I notice that I feel really annoyed that I need to pace myself. I feel myself getting tense just thinking about it. Take a breath. I notice it also makes me feel so sad because it makes me feel so different to how I used to be. This is really tough. Lots of people find this really hard, and I'm committed to helping myself through this tough time and trying it out. Maybe I can ask someone for help. So I hope that kind of demonstrates why I feel passionately that developing this ability to have a compassionate response to ourselves is so important. The other thing about compassion that I feel is really important is when we can respond to ourselves with compassion and kindness and wisdom and warmth, we're engaging this sense of safety. And when we engage with this sense of safety, it changes our physiology and it changes our brains, essentially. So when we're feeling in threat, if we're criticizing ourselves, if we are judging ourselves, when we're in threat, and I'm sure most of us can relate to this, our frontal lobes can kind of shut down a bit. And we find that we're not at our best in terms of making decisions, problem solving, seeing perspectives. I'm sure we've all had that experience of feeling really angry or anxious, and actually we're not necessarily operating at our best. It's just how our brains are set up. If instead of staying in that threat, we can switch into soothing and feel more safe, we can be kind to ourselves, we can get those frontal lobes back online, and we generally are able to be a bit wiser. So this self-compassion enables us to be able to problem solve more, to be able to connect with others. So I feel like being able to develop this is so important for then how we can then respond to what we need to do next. Just quickly to say, there are definitely blocks to self-compassion. I've worked in this a long time, and with a lot of people, they will feel it's too soft, it's too simplistic, it's too self-indulgent, I don't deserve it. It can feel really uncomfortable to treat ourselves kindly. What I often say to people is being able to develop an ability to relate to yourself with compassion is often one of the most important ways of us then being able to be there for others. So people often say, well, I haven't got time to be looking after myself. And the oxygen mask here is an analogy used that people find really helpful. So when people say, you know, I haven't got the time to be compassionate to myself, or I need to be there for others, I can't be looking out for my own needs and my own self-care, I'll say to people, have you ever flown on an aeroplane? And they give the safety brief. What do they say when they tell you about the oxygen masks? If the pressure in the cabin changes and the oxygen masks come down, what do they say? And hopefully those of you who have flown are saying, well, they say, remember to put on your oxygen mask first before helping others. And I'll say to people, well, why do they say that? And they say that because if you're traveling with somebody, maybe with a child or somebody else who's a bit more vulnerable, you won't be able to help them get their oxygen unless you first got your own. So you need to put your own oxygen mask on first so that you can be in a position to help others. So I would argue we need to show compassion to ourselves and take the time for that in order to then be there to show compassion to others, because being compassionate to others and being there for others is also really important for the vast majority of us. So I hope I have convinced you that self-compassion is possibly at the heart of effective self-management. It's at the heart of effective pacing, sleeping well, increasing our physical movement, connecting with friends, eating well, doing what we love, which I see as saying yes to life, and also setting boundaries, which is about them being able to say no. So I think I finished without being told I've overrun, which is marvelous for me. So
Thanks very much.
Getting
Thanks,
very close.
thanks very much, Lizzie.
Yeah.
You're giving me neck ache, do you know that?
neck ache.
Yeah, I'm sitting here, I keep nodding my head, everything you're saying, and going, yeah, that's right, yeah, that's it, I'll get that, yeah.
Good.
I think it's a good physio. No, I don't. No, very excellent, and you know, for me, ticking a lot of boxes there. Have you got any questions at all? I mean, I'll tell you, before I hand over to you, Gonya, you mentioned Vidya Mala, and I know Vidya Mala and myself. We both started off pretty much at around about the same time, and we met at the time I was working for Back Care. It was then known as the National Back Pain Association, and was up in Manchester, and she was there and I was there, and it was the first time I actually met someone else who was a self-manager, and she's done over the years. It's funny enough, we've been kept in contact, but it's funny how we both, you know, she's gone on to do fantastic work, you know, with Breathworks and all the other dudes that she works with, Sonia and her husband. I think her husband, isn't it Sonia? Sonar, is it Sonar?
I don't know.
Yeah, I know. Yeah, so I think yeah, because they have different names, don't they? I don't know. Sonar, I think it's Sonar. So Sona. I think that's how you spell it. Anyway, listen, I'll hand over to you before I get myself a bit of a pickle with names.
Yeah, there's not so much in the way of actual questions, although I have a couple of things that I wanted to say, because I think compassion in some ways, in probably not in the field of psychology, because obviously psychologists have been talking about these sort of things in their therapeutic relationships with people for a long time, but certainly in the world of pain and in physiotherapy, it's become it's a newer idea, and this idea of creating safe spaces for people, and it's certainly something I've seen very much in practice, that if people feel safe with you and if they feel safe with themselves, you're going to make a lot more progress than if they don't. And I wonder whether, you know, I just keep reflecting whether or not that we talked, you know, Nathan and I talked earlier about that importance of building that therapeutic relationship, taking time, you know, creating that sense of, and is that really ultimately all just about people feeling safe with us? You know, you make people feel safe with them. We're giving it all sorts of fancy names, but does it fundamentally come down to you create a safe space for somebody to feel
absolutely,
yeah,
absolutely. And I would say, I mean, for me, that's why that time, and I appreciate there are time pressures on different healthcare professionals. I'm not naive to that, but being able to form that, especially for someone who's coming in quite distressed, understandably, you know, people can be very frustrated by healthcare systems. They haven't always had great experiences. So people might be coming in with quite a lot of distress or anxiety or fear. So actually taking the time to really connect and help that person feel heard, understood, validated will enable them to shift out of that threat into a position where they're more able to engage with you and actually help collaboratively problem solve what to do next. Yeah. Because if they're just staying in that threat state, for any of us in that threat state, we tend to block ideas, we tend to block things, because it's really hard to think through and reason well when we're feeling in threat. So absolutely, for me, that connection piece of healthcare professionals to the people they're working with is fundamental to actually getting some sort of engagement and behavior change, because I don't think you're going to get behavior change without feeling safe.
Yeah, because you hear a lot of clinicians talk about the yes but clients, you know, the people who are like, yes but, and actually is that more about that for whatever reason we haven't been able to make them feel safe, as opposed to them not really wanting to engage with us or do things. It's that they're in that state of threat.
And I would definitely say it doesn't always take huge amounts of time. If you're with somebody who's doing that, yes, but try and see that. If you're a healthcare professional, try and see that as a message to you that there's something that you haven't validated. So actually, if someone keeps saying yes, but, it might be that actually they're feeling that you don't really understand how enormous this is in terms of the impact on their life. So it doesn't always take a long time. You can summarize and say, I can hear from what you're telling me that pain is affecting you in so many ways in your life, and it has been really difficult.
Yeah.
You can summarize it like that and think about, okay, what can we do to help you move forwards? But if you're getting a lot of the yes, but, then I use that as a cue to tell myself, I've missed something important here. This person doesn't feel I understand them fully. And usually it is the degree to which this has been very, very difficult for them.
Yeah.
Can I interject there a little bit?
Yeah.
I'm just conscious that we've run over time a little bit, and our next speaker is Keith, and it's 4 o'clock in the morning for him.
Oh,
So thanks very much for that, Lizzie. Appreciate that. Very thought-provoking. And we're going to move on to our next speaker. I know he's there because he's told me we've been in contact. So Keith, are you there?
I am.
Here he goes. Now, this is here we go. Yeah. First off, very good morning to you.
Good morning.
And so Keith Meldrum, how do I introduce this guy? Well, I'm going to tell you a little. I'm not going to break too much into your time, Keith, but I've known Keith now since, well, we knew each other like usual through social media, but then we had that meeting, I think that turning point in self-management in Boston, where we met at the IS Congress, where we did, we was invited to do workshops, etc. And that is when you became my teacher, a teacher. Because Keith talked about the importance of being resilient and stuff like that, and it's that to me is an important part of one of our skills really of self-management. But anyway, ever since we've myself and Keith, we started up the doing the World Pain Self-Management Conferences, as I say, next Wednesday in February. I'll be sending everybody details about that. But also Keith has been also co-author of several of the pain toolkits. I think one was after hearing Keith over in Boston at the time, I didn't really understand until then neuropathic pain was a bit different to musculoskeletal pain. So Keith was helpful in we co-authored a different edition of the pain toolkit specifically for people with neuropathic pain. And we also co-authored one for prehab pain toolkit. And anyway, and we've sort of been working together ever since, and we've sort of become, we call ourselves the Self-Management Brothers, etc. And also, I just want to give a shout out to those who are not watching this live from around the planet. I'm just going to give a shout out to my friend down in Australia, Mary Wing, who is she won't like me saying this, but she's probably sitting there in her 90 listening to the conference. But thanks everybody for around the world who's watching this. Keith, I'm going to hand over to you to do your bit.
All right. Well, thanks, Pete. Yeah, it's nice to be here. It's just bright and early here in the western part of Canada, 4 a.m. But I'm happy to have this opportunity to join everybody. And I had a chance to catch about a third of the last presentation by Lizzie, and that was amazing. I think that's such an important topic, and so I'm gonna do my part now here. I'll just get my my little presentation going here, and then we'll talk about a few things. So, there we go. So what I'm going to talk about today is, often I talk about what pain, supporting people that live with pain and supported self-management. As Pete said, that's what this is all about. But I want to take a little bit of a different tack this time and just also talk a little bit more about some of the things, just a couple of things that I believe that healthcare providers, and in this context, when I talk healthcare providers, I'm really talking more your frontline healthcare providers, so your MDs, and what they can do to better connect with people that live with pain, because it's an area that I'm very focused in on. It's part of the academic research that I do, and some of the other work that we're doing here in Canada is to really address some of these core competencies in medical schools, so that they can better understand people, not just their pain. So with that, we'll get going here. Just a little bit about me. So I am a recently retired civil engineer technologist. So I'm learning to know what it's like to have more of my time to myself. And just a little bit about my experiences with pain, because first and foremost, you know, I'm a human being. I'm not a person. I'm not my pain. I'm a human being. I'm married, got a son, dog, and a very fulfilling career. But in 1986, I had a near fatal car accident that left me with the neuropathic pain that Pete has spoken of. And as Mary knows, she's listening in, and I know she's going through a bit of a tough time right now. So hang in there, Mary. This neuropathic pain is really, really bizarre stuff most of the time. And then just for added good measure, fate felt it would be a good idea to hand me a rather some rare genetic disease called primary mitochondrial disease, which, in addition to a number of other symptoms, it offers new and additional pain. So, but with all my experience with my previous pain, at least I had an opportunity to understand what I was going to do about that, how to deal with it. A little bit about my advocacy efforts. Just like Pete said, he and I go way back to 2018. I haven't been doing this gig a long time. I go back to about 2011. I do a lot of, I speak to, present a lot of universities for pain education, pain conferences, part of the Global Alliance of Partners for Pain Advocacy Task Force. That's where Pete and I first met, was at IS to get that process up and running. Do some work here in Canada on a pan-Canadian advisory committee. But most importantly, and number one, is I get to be a collaborator with my good friend Pete on some pain toolkit stuff. So these are the things that I would like to touch on today. And I'm just going to sort of hopefully lay a little bit of a foundation of some of the things that I believe through my own experiences, as well as that of the many conversations I've had with people over the last 13 or 14 years, because there's a lot of commonalities that I see with those that live with pain and their experiences, both positive and unfortunately negative. And from those negative or the less than positive experiences, that's how we learn and grow individually, and how we can help systems and healthcare providers also grow. So with that, I bring up the biopsychosocial framework, and it's called a model or a framework. I'm a fan of this and have been for a long time, because back in the 70s, and sort of mid to late 70s, when it was pulled together, it was really that first step to really try to get systems, healthcare systems and providers to understand that pain is more than just the biomedical pain. I mean, all pain is biological, but we know now that it is influenced by so much more, and that's what the biopsychosocial framework really started to help introduce. Was there is the biological, there's the social, the psychological, there's the emotional. Lizzie's talk was talking about self-compassion, which is one of the most important things that we can do to help ourselves with emotions and psychology and our pain. And I think this is a great framework. It's a great building block as a foundation. But unfortunately, what I have seen and talked to others about is over the last probably 10 years, in my experience, maybe longer, but at least 10 years, this has been co-opted a lot in academic worlds, in medical worlds. So instead of being this Venn diagram where it all comes together and we see how it all meshes, all too often it'll be pulled apart. And so instead of being this sort of model, it unfortunately gets to be siloed. And those silos are used for people to support the particular biases. which as humans, we all have them. But unfortunately, I think that's been an unintended negative consequence of this model. But it is still fundamental and foundational to the underpinnings of people's lives with pain. So I share this because what I've seen lately, and started reading about this in the last 5 years from some work that another Canadian did, Dr. Peter Stillwell, is on enactivism. And simply put, this definition does sort of speak to it. It's the appreciation of the whole person and their interactions in their environment. That really is the critical part of this. And that's looking at the biopsychosocial model or framework through that environmental lens and how everything in the world around us, because we are people, we're human beings that exist in the world, and the world exists as this environment around us, and how that is impacted, how that environment impacts us. And if we start to look at it, if we flip that lens around a little bit, it's harder, I hope, to start to pull apart the overlapping circles of the BPS model, because it's this overarching, all-encompassing arms wrapping around us that's called the environment, because the environment that we live and exist in every single day has an impact on us. I think, something that Lizzie mentioned in her presentation is life is difficult. Even if you don't live with pain or any kind of long-term illness, let's face it, life is often challenging. It just is. When you add in, excuse me, when you add in living with persistent pain, that environment gets a lot more messy and a lot more challenging. So I offer this, excuse me, because we need to stop sort of teasing out the parts that really support our biases and look at the bigger picture and how the environment that people live in affects the totality of their life with pain. So now we're going to talk about a few of the things that I think are some of the building blocks of working with and supporting people. And again, I'm sort of picking up on some stuff that I heard Lizzie talk about. Validation. First, foremost, number one, it's the key that often unlocks so much for people to allow them to start to move forward. It was an experience for me for many years. My pain was not validated. I was actually told at one time, 3 years after my car accident, that there was nothing wrong with me anymore. Everything had been fixed, and it was all in my head. That, I would suggest, does not meet the first do no harm ethos of medicine, because that was, and I mean, it happened to me, but it happens to millions of people. Their interactions with healthcare providers are, I can't see it, so it can't be that bad. That validation is critically important, and it's simply, it's not difficult. It's the act of having a person's pain experience being confirmed as being real. And for me, that happened in 2004, late 2004, excuse me, when for the first time a healthcare provider just looked at me with just compassion. I was going through a medical intake for an intervention, and he could tell that I was sort of disengaged and just reading or just citing my history by rote, because I'd probably done it 50 or 60 times. And he just stopped and he looked at me and he said, "We believe you." And that simple statement was the beginning of an opportunity for me to start to look at my life with pain differently, because it allowed me to stop fighting the system and that environment that we live in, and that environment that was putting negative interactions on me. This was an opportunity to start to see things a little differently. So validation is absolutely key. I want to talk about our friends in the healthcare system, because I do have a lot of respect for them. And when I talk to healthcare providers, I'm really talking, in my experience, I'm seeing it again in those, in the MD settings. Let's face it, people go into medicine to fix and to heal. That's why they do it. And we need that. And they do amazing things. And I mean, in my car accident, I nearly died, and they saved my life. There's just no two ways around it, that they are extremely, incredibly bright, focused, dedicated individuals, but their focus is about fixing the problem and solving the problem that's in front of them. That's what they're taught in medical schools. You've got symptoms, the list of symptoms show this, we do this intervention, or we do this procedure, we fix the problem, we check the box, and that we've got the patient cured, and then we move on. As we know, often, pain is not curable. Persistent pain is not curable. Now, some people have, they can get their pain much better than it was. But for many of us, it's just something that we live with every single day. I always refer to it as the shadow that walks beside. Sometimes that shadow is a little bit behind me. Sometimes it's right beside me. And other times it's up front trying to trip me up, but it's always there. And we need to understand that when we put ourselves, or people are in front of these healthcare providers, they're going into a situation where the room is, you've come to me so I can fix you. And when I can't fix you, I don't know what to do. And we need to change that. And we need to let them know, first of all, it's okay that you can't fix or cure this thing. But critically important to your next steps are what you can do to support the person living with pain. Because all too often, when they come up against, I don't know what to do, they are told, as I was, and I'm sure many people who live with pain, what do you want from me? It's not really very compassionate, is it? So we need to focus on teaching them and supporting them to support those that live with pain. We got to cut them a break. We've got to understand that they've been taught to fix, and it's not always fixable. And part of that support, underpinning that support, in my opinion, is something as simple as empathy. We talk about it a lot, but it's something I think we need to actually put in the forefront for healthcare providers, especially in their medical training, because empathy doesn't cost anything. Other than a little bit of time. And it's pretty straightforward, but being an engineering type, I like definitions. I'm a black and white guy. Empathy is the action of understanding, being aware of, sensitive to, and vicariously experiencing the feelings, thoughts, and experiences of another. I'm not saying that we need every healthcare provider to try and put themselves in our position and feel what we feel, but we need them to understand, be aware, sensitive to the feelings, thoughts, and experiences of another. So not to be dismissive. Validation is one of the first parts of empathy. I believe you. This must be hard. Your pain is real. What can we teach some healthcare providers to do when it comes to empathy? Again, these are not difficult things. They're being present for the person, giving them space. Often people don't even have time. Many people who go to talk to somebody about their pain, they're rushed through. And this is a systemic issue. Like I don't profess that by training healthcare providers differently, we're going to fix the system, because the system now needs to be adjusted to give them the time and the space that healthcare providers need to be present for people. But there's still little things that they can do in a healthcare setting. That critically important clinical encounter, which is often very stressful for people. Being present, looking people in the eye, actually listening to understand, not rushing through to their next question or to their next point. Listen to people, give them the time and the space to say what they need to say. When you actually listen, you will hear what the person's saying. I go back to what Lizzie was talking about, or Grania, you talked about the yes, but. Often that's because people are not being heard. I strongly agree with what was said in the last presentation. Letting go of biases. We all have them. It's also important to be open to understanding that maybe not everything we think is right. And most importantly, acknowledging feelings. I'm not asking MDs to be psychologists, but they can be, and every healthcare provider can be psychologically informed. And when you acknowledge feelings, again, it doesn't need to be this large event, but it's simply acknowledging the person's feelings. This must be really hard for you. I'm sorry this is happening. What can I do to support you? What is it that you are looking for in our meeting today? Like just being one human being talking to another human being. And empathy, it costs so little, but the return is like, it's more than synergies. It's not one-on-one, is 3. It's 1 and 1 is 10. When you actually listen to somebody and you give them the time and the space to say what they need to say and to be heard, that is critically important. I think it's a little bit ironic that in healthcare, I haven't seen in the various curricula that I have reviewed for healthcare providers, they never touch on any of this. It's all very, very mechanical. It's all about here's the issue, here's the solution. And I really strongly feel that's a change that we need to work on. When we go through these processes with the healthcare provider, when we have them understand that validation is critical, the importance of empathy is really critical. This leads to acceptance or willingness on the part of both people, the person living with pain and the healthcare provider that supports them. And this is a really crucial point. And for many people, you can't reach this point of acceptance or willingness until you've gone through a positive healthcare provider experience or experiences. So validation, building a rapport, having therapeutic alliance with your healthcare provider, feeling like you're being listened to, that you're a person, that you are not just your pain. Because let's face it, often the pain isn't the only thing that is causing them to come in seeking help. It's the pain and all the things that entails and the environment they live in that puts on them that exacerbates that pain. So it's a bit of a knotted mess, but until we take a step back and look at the bigger picture, you're never going to untie those knots and get to this position of acceptance or willingness. And I use both terms because a good friend of mine, Dr. Bonnie Lennox Hobson, said, acceptance can be a very difficult word for people that live with pain. When you say, well, you need to accept that your pain will be with you for a long time, because that often for many can feel like giving up or saying it's all on me, or the system has given up on me and there's nothing more they can do. So she likes to use the term willingness, in that when am I, a person who lives with pain, willing to do or to try to live better despite my pain? And this can also be now seen on the same side as the healthcare provider. What am I, healthcare provider, willing or able to do that is outside of my norm of a needle or a surgery to support this person in what they need to be able to live better with themselves? But none of this can be reached until you go through the processes of validation, empathy, therapeutic alliance, and building a relationship as two human beings coming together equitably and respectfully to deal with this issue. There's a Canadian actor I hope many people have heard of, maybe not, but his name is Michael J. Fox. He's actually also from British Columbia in Canada, where I live, not in the same city. Unfortunately, tragically, he was diagnosed with Parkinson's disease at a fairly young age, and he's a huge advocate for that illness. And I love this quote because I think it says so much. And he had said, "My serenity is directly proportional to my acceptance and inversely proportional to my expectations." And again, I would offer that goes both ways for those that live with pain and those that support people that live with pain. We need to set aside these expectations and move more towards acceptance, because that is the path forward. That is how we find a way to move through these knots and these challenges. All of this, when you start with the foundation at the bottom and you start to build on top of that, culminates in one of the most important things that needs to be always considered in my opinion, for people that with pain, is supported self-management. I'm not always saying it's the only solution, but I think we always need to have people look at this as a very viable, safe, and effective option for people. But it needs to be presented as more than just here's a little pamphlet on some things that's called self-management, go away and do it. When you have this healthy, equitable, validated, empathetic relationship with healthcare providers, and you have somebody who lives with pain who now feels heard and understood, and they now feel like maybe there is something they are willing to do differently than trying a medical intervention because they don't always work, or in addition to interventions to help themselves. This all now culminates in effective supported self-management. I won't read you the quote. It's on the sort of definition of supported self-management. This comes right from one of the NIH articles that I found. And I think we all pretty much know what it is, but the emphasis on this, in my opinion, is the supportive portion of it. Because when we talk self-management, again, it feels like we're telling the person, here you go, you need to do this. And while those of us that live with pain, we have a necessity, and even I would offer a responsibility to do what we can, it's not always done exclusive of our healthcare providers or the system. I lean heavily into self-management, but I am also well supported by my healthcare system. I do get interventions. I have a medically implanted device. I am the walking, talking definition of a patient who over the years has been able to develop a more effective supported self-management process. So I see my healthcare providers when needed and necessary. And outside of that, I am doing what I need to do and when willing and able to do to best help myself live despite the pain. So that really kind of takes us to the end here. I didn't want to burn up too much time. I know you guys are getting close to the end, but that's my thoughts on today's presentation.
Thanks very much, Keith. Excellent messages there. Oh, you know, it's just, you reinforce. Well, I think it's the reinforcement that actually self-management works, and like as in Ruth earlier, when she was describing how she manages her pain and how her pain management has helped her over the years, etc. And I think I made a comment there that you right at the beginning of your presentation. I'm not my pain,
right?
And we're not. I'm not. You know, I'm Pete, and you know, it's that phrase I use. You know, keeping yourself in the driving seat. You know, I'm the driver. The pain's in the passenger seat, back seat, in the boot. I don't really care where it is, but I'm running a show sort of thing. But I am who I am. Have we got any questions there, Grania?
Well, there was a couple of sort of things put in there. Lizzie put in a really good point early doors, and it's not it's kind of to sort of say, wondering whether sometimes on the part of healthcare professionals, when they feel they can't fix things or when they're confronted with something they can't fix, because often, as Nathan and myself said earlier on, that is one of the reasons sometimes we go into healthcare, is because we want to help and fix and do things. But as a psychologist, Lizzie sort of saying that what can that often lead to is people feeling incompetent and de-skilled. And that's their feeling. It's not the reality. It's not that they are incompetent. It's a different situation. But obviously, depending on how they talk to themselves, Lizzie did her talk about self-compassion. If they then talk to themselves critically and they're feeling incompetent, and then their inner voice is saying, you are incompetent, you haven't been able to fix this person, does that then change how they relate to the person they're talking to and then make them feel that they're disbelieving people? And it's why it's so important for when you do come up against those feelings as a healthcare professional, because you will, I think Helen acknowledged that as well, you know, you can feel when you want to help and you can't help, and you know this is not something that you can fix. You have to be reflective on that yourself, and you have to analyze how that makes you feel. And that's an onus we have on us, I think, as healthcare professionals, to be open to exploring that within ourselves and how it makes us feel, because otherwise the risk is we react in a way that then puts that onto you as the person living with pain and making you feel disbelieved or not feeling sort of safe with us. So we have to be prepared to explore and be curious about how we feel about things like that. So I think it's really important. I see Helen's got her hand up.
Helen.
Hello, everybody. Yeah, I was just going to say that working in pain care has challenged me probably more than any other area of practice in 30 years. And I think I'm grateful that I feel that it's made me more human. I started off my career trying to be very professional with all the boundaries in place that we are taught to have in our work. And I realized over time that it's not professionals who support people best or help people best, it's humans. And so being more human has been an important lesson from reflecting on powerlessness and all of these uncomfortable feelings practitioners feel.
I think that's, to both points and Grandy, what you were talking about, I think when that sort of feeling of I can't fix it, I think that often leads to a lot of the dismissive encounters that people experience. And that's not because the healthcare provider is deliberately being difficult, but it's this like, I don't know what to do. And that's why one of the work, some of the work that we're starting to do here in Canada is to get back into the education system. So when people start their training, it's going to be like, you can't always fix it. And that's okay. But here's what you can do. It doesn't mean you can't do anything. So if your tools, if your scalpel or your needle or whatever it is you have isn't the cure, you have this amazing thing called you as a human being who can be empathetic and connect and can support. Because there's many, many things that you can do. And we need to, we got to let people off the hook and say, it's okay that you don't have the cure. It's all right, but it doesn't mean you can't not do something. And to, to Helen's comment, I think it is important to bring some humanity and compassion to a clinical setting, but I'm also, and I'm not a healthcare provider, but I'm also aware that there still needs to be enough protection for the healthcare provider because of all the people they see every day, that could be pretty overwhelming and burn them out really fast. So it's a real juggling act, but no compassion, I don't think is the solution, and being overly compassionate could just burn the person out. So it's that sweet spot in the middle somewhere.
Keith, I know I keep being aware of what time it is there, and I want to let you go and get some Zeds.
I'm probably up now, man.
Oh, don't start. I mean, don't get in my habits, mate. Anyway, listen. Thanks very much for coming on today, and I appreciate it. And I'll be in touch soon. But so great presentation, great messages. I mean, if you're watching this live or you're watching the video, the recording, I mean, I know you're going to get so much out of it. So, Keith, I'll let you go. Helen has introduced herself a little bit already. So, he's gone already. I was going to say if he wants to stick around now, he's up. But he's gone.
Oh yeah, no, I'm just going to turn my video. No, I'm gonna hang out and listen. You bet.
Oh, sweet. Well, nice one, dude. All right, catch you soon. So, Helen, so you, I think, I'm taking away your job there, Grania. Grania's going to introduce you, and I just want to say, Helen, since we've been in connection now, I've really enjoyed watching your work, and it's taught me a lot. So, but anyway, I'm taking away Grania's job, and I don't want to do that. Otherwise, I'll get it in her neck. I know I will. But, over to you.
Well, yes, no, it's a privilege to get. You'll notice, those of you that have been here for the whole conference, that we very much split this along boys and girls lines. Pete introduced all the boys, I introduced all the girls, and that's just the way the cookie crumbled. But Helen is an occupational therapist from South Africa, who I've had the privilege of knowing online for a while now. One day, hopefully, I will get the opportunity to meet you in person, but you've given us a presentation on our last conference for Southern Hemisphere, which was brilliant. You've been supporting adults living with persistent pain for a long time now to help them become effective self-managers of their conditions. And as an occupational therapist, you bring that wonderful skill and practicality that occupational therapists all over the globe bring. Every pain supporting service needs occupational therapists in it. There aren't enough of you in the world, so we're very grateful for you. And you're going to give us a talk today on, I think, the importance of saying no. Is that right?
That is right. Yes.
Yeah. So over to you.
Thank you. So just sharing my screen and getting where I need to be. All right. Yes. So I'm sorry I missed some of this morning's presentations, but I'm sure that they were incredibly useful. And My presentation is really about quite a simple subject, but I chose this because it's something I see coming up over and over again, is the difficulty around saying no. Boundary setting. I tend to find myself exploring the subject over and over again with people that I work with. So I want to talk about the pain self-management skill of saying no. And I want us to maybe answer some questions today. So I'm going to recap a little bit what is supported pain self-management just as we end this whole morning. And then look at where does saying no fit into supported pain self-management? Why is it hard to say no? Who do you need to say no to as someone living with pain? And then how can you say no nicely and manage those who can't take no for an answer? So I am going to try and be quite practical with this presentation this morning. So first, let's just recap what self-management is and what it involves. As I have presented before on this platform, I often use the hiking metaphor to describe what the journey of pain management is like, what the self-management journey of pain is like. And I say to people, it's like a journey over some really difficult terrain. There's going to be twists and turns. There's going to be uphills and descents, really tricky navigation sometimes some easier bits. And so you're on this tough hike, and to go on a hike, it doesn't just require having the confidence that you're going to get to the end. You actually need to have certain knowledge, certain skills and tools to pack into your backpack for this hike that you're going on. And so if we look at pain self-management, it is essentially the confidence, knowledge, and skills needed to do three main tasks. And the first of those is really to engage with healthcare services and practitioners, learning how to work in therapeutic partnerships, asking questions, sharing decision-making, and so on. Then it's also about some of what's probably been covered today. It's about how to implement what's been recommended by practitioners, how to implement things like physical activity or meaningful movement, sleep hygiene, and so on in your daily life. And then it's maybe most importantly about being able to live life despite pain. So it's about the life all around the pain, living well with pain. And there's so many skills that can go into that. Keith's spoken about acceptance, there's flexibility, there's problem solving, goal setting, there's so many of these things. So these are the tasks of self-management. Now, where does the skill of saying no fit into these? Well, I would suggest that it fits in everywhere. And we're going to unpack some examples later of where I see it playing out the most. But as I often say, even if you have that bulging backpack with all the latest pain self-management gear, and you're an experienced hiker on this pain self-management journey, as other hikers in this group will know, there's one important rule for hiking, and that is you never hike alone. And so we do talk about supported self-management. The support from healthcare practitioners and non-healthcare practitioners in your support system is so important. This is a group hike that the person with pain is on. And we are sharing knowledge and skills that we might bring to that, and we are navigating to the destination together. And as we'll see, getting the right kind of hikers to go on this journey with you is going to mean learning to say no. But this is something that many of us find hard to do for many different and more complex reasons. But I just want to address two things we need to know about pain. Why is it so hard to say no? Well, at the most basic level, we struggle to say no because we see it as rejecting of a person or people. And because as humans, we are essentially social animals, we fear that we will lose the support we need for our very survival. And so we tend to hold on to these two problematic beliefs about saying no. We say saying no is personal. It means we are rejecting a person or people. And we think that saying yes is always preferable. We should say yes more often than no. But I want to highlight that the counter beliefs to these are more helpful to embrace. And they are that when you say no, you are just refusing a request or rejecting a suggestion. You are not rejecting a person. And actually, you are saying no more often than you think. Why? Because whenever you say yes to one thing, you are by default saying no to something else. You just don't realize it. And sadly, it's often yourself and your self-care that you are saying no to. So your struggle to say no is a struggle we all share, but each one of us might also have a history with the struggle to say no from past experiences, whether it's with family or horrible bosses or whatever it is. And we might want to explore that history in psychotherapy too, so that it's easier to learn to practice the skill. So challenge your beliefs about why it is so difficult for you to say no. Then who do you need to say no to on this self-management journey? Well, I think you might need to learn to say no to yourself, to say no to healthcare practitioners, and then to many others that form part of your support system. So partners, family, employers, and so on. So let's just look at some of the examples of struggles to say no that I've come across in my clinical experience that you might relate to as well. So firstly, saying no to yourself. In my experience, and I think there's research to back this up, people living with pain often fall along a spectrum of coping with life and pain that goes from one end of what we call maybe persistent endurers, so people who push on, all right, might tend towards overactivity. So this might look like even pushing medical management too hard, overdoing functional activities. And then on the other side of that spectrum, there might be people who are coping by doing much less than they can. There's a more passive approach to the problem. Wherever you fall on this continuum of coping, you might need to learn to say no to yourself with some things. If you relate to that pushing side of the spectrum, pushing hard, no pain, no gain, overactivity, you might need to learn to say no to too much activity and too many commitments. If you're on the other side, maybe a more passive approach, more underactivity, you might need to say no to too much rest. So we all need to learn to say no somewhere. The question that I like to encourage people living with pain to ask themselves about any new activity or commitment that comes up, someone's inviting them to something or a new activity comes up for them, is firstly, is this something that I want or need to do? And that's a yes or no answer. But from there on, it's not so straightforward. If the answer is no, then say no to yourself and don't do it. But if the answer is yes, ask another question. And that is how? How can I do it without paying a disproportionate price in pain? In my experience, people living in pain often say no to things that they could have rather asked this question of how in response to. So rather than just a flat out no, asking, how can I do this? What are the adjustments I can make? What is the assistance I can bring on board, the support I need? And then make those changes and be able to do it. So don't think that everything's an easy yes or no answer. Don't say no more often than you need to, but say no when there is something that you don't want or need to do. So saying no to yourself might be a place to start. But then there's also a place for saying no to healthcare professionals, healthcare practitioners. It's part of that medical self-management, that shared decision-making. I see this very much, this relationship, as this therapeutic partnership where we want to partner together, we want to align our goals, we want to share power. And for me, sharing power is being able to say no and hear no from each other. As a healthcare practitioner, I need to be able to hear no from the person living with pain that I'm working with. I need to be able to say no at times, and vice versa. From my point of view as a practitioner, and especially in my South African context where we have a poor history of upholding human rights, and we haven't respected the autonomy of the individual, and we haven't exercised justice as we should have. And then on top of that, working in a health context with a biomedical model and hierarchical kind of relationships is the norm. I find that many of the people I'm working with struggle to say no, struggle to share decision-making with healthcare practitioners. And so I've taken it upon myself, because I'm aware of that power imbalance. I feel it is my initiative, I need to take it on myself to intentionally and actively encourage those I'm working with to say no to me. So I, as a practitioner, might need to say things like, feel free to disagree with what I'm saying or disagree with me. Or I will say things like, you're welcome to say no. You're welcome to ask questions. Because unfortunately, at this point in time, in this context that I work in, I can't rely on the person to feel empowered enough to disagree, empowered enough to voice their no. So I'm acknowledging the bias and power, and I'm actively trying to restore some balance, and I'm inviting the no, and I'm hearing the no, and negotiating with someone with pain. From the person with pain's perspective, I can only say, recognize that you are allowed to say no and ask questions and find your voice. Then taking it beyond that relationship, there are others we will need to say no to. So the family and support system of someone living with pain often have the best intentions. They love you, they want the best for you, but they might not understand your pain. They might not understand how you need to manage it in the way that you do. And so, yes, there is a need to educate your support system, but I think also a real need to protect your pain self-management plan from the best intentions of others by saying no. So two ways or two scenarios I see this happening a lot in is, for example, when myself as a practitioner and the person I'm working with come up with a graded physical activity plan. And then we decide that it would be great to get some support on board. So maybe the person is going to start jogging with their partner. But I've had experiences where the person I'm working with comes back to me and says, I was doing okay, but then my partner said, you're having a good day, you're feeling better, so let's do a bit more. Come on, you can do a bit more. Let's do another 10 minutes. And that pushes the person into overactivity and ultimately leads to a flare. We can get the opposite too, where you have a physical activity plan you start on, but your family members are overprotective and they want to stop you doing things. There might be a need to say no there. The other place I find saying no comes up really often is in the pacing plan. So we create this pacing plan, we embracing this idea of having alternating periods of activity and rest, appropriate rest between these periods of activity and so on. And then there's an invitation to a family gathering, which you know is going to involve hours of loud music and standing and engaging. And it's difficult to say no, but that might be a trigger for a flare. So pacing often comes under these kind of challenges from family and other members of the support system. So those are two places I see it coming up a lot. Getting really practical with some ways of saying no, using this invitation of going to a party maybe as an example. I'm just going to give some ways of saying no nicely. I don't even need to really explain these. These are things to use, but firstly, the simple no. This is the direct, unapologetic, simple no. You see, when you start with, I'm sorry, but, that often negates your response. Be polite, be firm, and stick with just a no, I won't be coming to the party. Thank you. Quite a simple no. Your other option is the sympathetic no, and with this one you reflect a little bit of the emotion or the content of the request from the person, and then you add the no at the end. So you can say something like, I can tell that you really want to have me there, but I won't be coming to the party. So that's part of that empathy, that reflecting of emotion, but still being able to say no at the end. What about this one that I call the seasoned no? And what we mean is that this no is seasoned with reasons or values. So it's not just about feelings, there are reasons and values attached to the decision you're making. So here you can give a genuine and brief reason for the no, such as, no, I will not be coming to the party because I need some time to rest. Instead of just rejecting the request, you're giving a reason that shows you care enough to have thought about it and made an informed choice. If you don't have a reason right away, you can use the sometime no, which I'm going to get to collect your sort of thoughts. But it's also okay not to give a reason at all. That's what the simple no was about. The seasoned no also gives you an opportunity to communicate values, because you can say something like, no, thank you. I won't be coming to the party because I value this time with my family. So seasoning your no with some values or some reasons. The fourth way you can say no nicely is probably my favorite, which is the sandwich no. And the sandwich is made up of two positive responses with one no between them. And since the last thing the person hears is something that sounds positive, it is easier to hear that no in between and to leave that interaction feeling good. So for example, you might say, I enjoy your party so much, but I'm not going to make this one. You're so kind to include me again. Thank you. So sandwiching your no. And my final suggestion for how to say no nicely to someone is the sometime no. Now, this is a delayed response to give you time to think about it. So you can say, I'm not sure. I will think about it and get back to you. But be careful not to confuse it with delaying making the decision. So it's not the same. Sorry, be careful to not confuse delaying making the decision with not wanting to make it. So in other words, you're not going to just say, maybe I will come, I will see, because that sounds like a yes to most people. You're just saying, I need time to think about my response. Right. What do you do with someone who can't hear your no, who kind of wants to just use guilt and shame and fear to manipulate you? So this is the person who just says, but you never want to come to my parties, or I'm going to be left to do everything myself, or I came with you to that last party, I'm always doing things like that for you. For an emotional manipulator like this, you might have to respond with some different approaches. You can use short phrases that acknowledge their emotions, but don't compromise your response. So saying, I know, is that so? Sorry you have to face this. This must be hard for you. Whatever they say, don't be guilted into changing your answer. The alternative is what we call the stuck record technique. And this is where you continue to repeat your chosen response as many times as you need to, while they continue to try and persuade you. But your message doesn't change and it will sink in. Finally, I want to say we call saying no a skill because it can be learned and practiced and developed. It is like a muscle, your say no muscle. So I suggest you start practicing saying no in small ways, saying no to people you feel the safest with first, and to demands with less important consequences. And then you build up your confidence and your no muscle. Thank you for that attention to that. My book, in which I cover a little bit more around boundary setting and saying no under stress management, is available out there. But thank you for your attention. And are there any comments or questions on the subject?
Thank you, Helen. It's fantastic. I like that. It's given me some ideas about saying no. I'm a bit of a yes person, but I've got better over the years. But give me some tips there. I appreciate that. Gonya, have we got any?
Well, we've got lots and lots of really positive response to the ideas of the different types of no's. It's just brilliant. It's really quite so simple, but kind of really helpful to people to think about those different the different ways of doing it. I particularly like the seasoned no's and the sandwich no's. It made me reflect of what I'm most guilty of whenever I do it with people, and I'm definitely an apologize first before I say no. And I'm curious now about why I always do that, because I kind of find myself doing that when I say no. I'm really sorry, and it's like, what? Why am I saying I'm really sorry? So I think really, again, it harks back to everything that sort of Lizzie and Ruth and Keith and everybody sort of said before, the importance of really understanding ourselves and really sort of being curious about ourselves and why we do things and say things, and reflecting on that so that we can learn these skills. Because as you say, it is a skill to say no, and it doesn't come easy, but understanding why it doesn't come easy and what way we tend to do it is really important. So yeah, I think it's something that we will all obviously also keep learning to do, because you don't master it. Nobody masters it. There's always something new that sort of comes along. But I don't think there was any specific questions in there.
I've got one.
Oh, there you go. He's going to go in there.
And I'm going to go back to, I came in partway through Lizzie's presentation, but for people that live with pain, Alan, how much of the challenge with not being able to say no might be wrapped up in the emotion and the psychology and all of that, of not wanting your pain to be the thing that defines your life? So you're like, if I say no, that means I'm giving into it. So I'm going to do this thing because, by God, I'm going to show it I'm more than my pain, and I'm going to get back to being the person I want. All of that sort of grief and loss that has probably not been resolved. And you're like, nope, I'm doing it, even though it's the worst thing you can do.
Yeah. So totally, Keith, I hear where you're coming from there, and I think I try and encourage people to weigh everything up. So there's no outright yes or outright no to most things. Some things there definitely is, but I think I try and help people reflect on that and look at costs versus gains with everything, and say, okay, look, you can choose to still go to that party for 4 hours. You will enjoy the social interaction. You will love this and that about it. It will do this good and that good. But then there will be a price. As long as the gains outweigh the price or cost, that's okay, So yeah, I think it's that constant weighing up and sort of, what are you going to get from this? But what's the price you might pay? Are you prepared to pay that? Sometimes you are, and that's okay. Yeah, so I find it's this constant negotiation within the person themselves, but also I try and articulate that negotiation with them so that they can see that everything in life has a cost and a gain, but we just want most of the things you're doing to have more gain
Yeah.
than cost. Yeah.
Yeah, I love that constant negotiation and being able to find a space to be able to say honestly with yourself, yeah, I can do this, but yeah, like you said, there's going to be a cost, and so will there be more pluses than minuses? And if there is, then good. But instead of that blind, almost rage emotion, that's the only way I can, is just I'm going to do it because I don't care. I'm going to show everybody I can be the person I was, and then it just completely unravels. So I love that. Yeah, the constant negotiation. Yeah, thank you.
I think, I mean, coming back to resilience, I heard it come up just now. For me, resilience is responsiveness. It's not a static state. Hey, so for someone to be resilient means they must be able to be responsive. There's a fluidity, there's a flexibility. I think that's what we want to encourage in people is responsiveness. Not everything's a no, everything's a yes. Some things are yes, some are no. It's responsiveness. Your nervous system is adjusting all the time, regulating all the time, up and down, up and down. Yeah, that idea.
Yeah, I love that.
And you know, as a close, sorry, Pete, I just want to say as a closing sort of thing, that really for me ties in what I see and hear and feel is often a challenge for healthcare professionals, is that we quite often want stuff neat and tied up with both. We want, people want answers. They want to know what exercises should somebody do for this condition, or what should pacing look like, or what should acceptance look like, what does resilience look like, what does values-based activity look like, what's meaningful movement look like. And the reality that we've learned from everything this morning, from listening to Ruth, from Keith, from everybody else, is that it's different for everybody. It depends. You can't have that rigidity of kind of, this is the only way, this is the way you must do pacing, this is the way you must do. And even for individuals, it's not going to be the same at every stage in your life, because other stuff's going to come in. And as Ruth said, when she was in her 20s and what she did at the Input Pain program and how she implemented her self-benefit at that point in her life, she couldn't do now because she's got a young family and different things to do. So it's about helping people to learn that flexibility and that adaptability and that ability to understand themselves enough to change how they do things depending on what stage they're at. And clinicians, we have to be able to be that flexible. We can't stick to those rigid things of, this is what I've learned and this is what I think is the best way to do things, or the evidence at the minute tells me this. If the person in front of you says, yeah, but for me, this is going to work really well, we can't dismiss that. So we need to be flexible, as well as encouraging people living with pain to be flexible and resilient. Sorry, that's my little soapbox. I'll just get myself down in there for a minute.
Well, echo that. I'll tell you, listen, Helen, thanks very much for. I'm going to have to go watch your section again, because there was so much info going on there. I can't take it all in. Perhaps I'm just the old guy in me. Hey, listen, we come to the end of the conference, and just want to say thank you to all of the speakers, all of the presenters, who, for me, it's been another fantastic conference, really, and they just keep getting better and better, with the speakers and the messages, etc. Also, I want to thank Ronya and Dave for their ongoing support. It's second to none, mate. I really do appreciate it. I wouldn't be able to do this without you guys, but we're sort of a bit of a team now. So the next conference that myself and Keith, I think Ronya and Dave's going to be involved in, is on the 8th of February. If you're living in the UK or the Europe, the top part of the world, etc. But if you're living down in New Zealand and Australia, that end, it'll be on the 9th, so it'll be your morning. But in like North America and UK and whatnot, it'll be on the 8th of February. and we've got some really great speakers for that as well. But anyway, just want to say thank you again for everybody who registered for the conference, and I'll be this afternoon. I'll be downloading it onto the computer, and then probably may take the rest of the weekend, but I'm not sure. I think it will, but upload it to YouTube, and then what I'll do is everybody registered will get a dedicated link to them, where they can rewatch or watch it for the first time or watch it again. So any other closing messages? Keith, I don't know if you're still there. Have you got any take-home messages for anyone?
Oh boy, put me on the spot there, brother. Again, I didn't catch all the speakers, but everything was amazing. I personally would like to thank you for the opportunity to join you guys this morning. But every time I get to be part of one of these, listening to Lizzie's presentation and then yours, Helen, I guess I'm not too old to learn, because there's still so much that I learn, and I have all these thoughts sitting in my head, and the next sort of presentation or something that I do, I know all that I've taken today will factor into what I do. So amazing, Pete and Grania and Dave, thanks for all of your efforts in doing this. It's really appreciated, and it's really important work.
Dave, what's your take-home message from today?
I don't think you can summarize it down to one, because there were so many things. But as Helen went last, it's the one I can remember. Nothing to do with goldfish brain or anything. But at the power of saying no. So given that the 8th of February is going to be the middle of the night, I'll start practicing now. No.
Oh, come on, Dave. And Helen, what's your take-home message for everyone before we all ride off into the weekend?
Pete, I would just like to say that I think we must continue to cultivate this partnership. It takes practitioners and people living with pain together to share this. We're sharing power, we're sharing this partnership, and we mustn't fight each other. We must come together and work together with this.
Thanks, Helen. And Grania?
Well, just 100%. And I, as a clinician, and I just think especially that I think I am so grateful for those of people who do live with conditions, who aren't, sort of healthcare professionals, or aren't sort of doing this as their job year in, year out, to I'm thinking of Ruth in particular, to come here and to open themselves up, to show that vulnerability and tell their truth, tell their story so eloquently. Each of you, it just humbles me, and I'm so grateful to be able to have the opportunity to be part of these things, because you're right, Helen, we just need to keep doing this together. We are not the be all and end all as clinicians, and we've got to showcase and fight for the fact that this needs to be equal partnerships all around.
Well, there you go. Thanks everybody for watching. Thanks again for everybody registered, and we'll see you hopefully in February next year. Be cool and groovy. Look after yourself. A lot of people say to me, "What do you actually do, Pete?" I said, "Well, I've always got two jobs. My first job is looking after myself, and then my second job is meeting lovely people like you guys." So on that, I wish you everybody a happy groovy weekend, and I'll see you again soon. Take care. Ciao.